and increase the therapeutic outcome.
So, Professor, nowadays can the young people or the pediatric use radiotherapy? I mean, while instead of the let's say, is it safe for them, especially for the younger people? Because the studies showing that, sorry, maybe there is, the old studies showing that it's not safe for young people to use radiotherapy because they will induce different kind of cancer.
Very good question. Actually, the use of radiation in medicine governed by one basic justification. I mean, if qualified medical physician believe that or decided that the benefit of radiation therapy or diagnostic imaging it outweigh the radiation probability of cancer, so we use the radiation therapy or diagnostic imaging. Sometimes, especially in diagnostic imaging, people believe that if you do an X-ray today, you cannot do it tomorrow or after tomorrow. This is not true. The pillar of this is just justification. If competent medical doctor decided that the benefit should outweigh the radiation risk, so we go for radiation directly.
Excellent. Finally, this is final question. What is the secondary cancer is commonly associated with the breast cancer after radiotherapy treatment?
Yeah, angiosarcoma is one of the common cancers, and ductal carcinoma also. These are two more common type of cancer, breast cancer induced. For the other breast, you know that we treat the one breast most of the time, and the other breast exposed to high scattered radiation. So this scattered radiation can induce a secondary cancer after latent period. This latent period could be from 5 years up to 18 years. For that, but radiation therapy itself can increase the survival rate up to 25 years, so that the benefit of radiation therapy is far outweighed the radiation risk or secondary cancer induction. But we have to monitor the patient carefully in order to detect the radiation-induced cancer as early as possible in order to treat it in prompt time.
Thank you, Prof. Abdulmonem. Is there any other question?
Yes, I think we have one raising hand question from attendee, Dr. Al-Jaili Yusuf. The mic for you, it's open for you, Dr. Al-Jaili, you can speak, please. Dr. Al-Jaili, open the mic from your side, please.
Assalamu alaikum.
Alaikum salam.
Thank Prof. Abdulmonem for very nice, interesting topic. The start of radiation therapy start very early at that time. Do you think the risk of giving very high energy of radiotherapy for our body more than the benefit of the considered radiation or at that time they consider radiation protection and direct the radiation for the certain tumor with collimation? Also, recently, do you think radiation therapy should follow any surgery or chemotherapy is better and enough according to the recommendation of that according to recommendation of oncologist?
Yes, thank you very much for nice questions. We have radiation therapy actually was very successful for patients, increased the survival rate for patients. Actually, the victims of radiation in early century or early days was the physicians themselves, because they used radiation without protection and they treat many patients as much as possible, so that physicians were the main victims of the risk of ionizing radiation, while the patients were benefited for sure from use high energy radiation, because for limited time, but for the physician in daily use, he used ionizing radiation. The second question, just when we use radiation therapy nowadays, we can increase very high the radiation dose, and we can reduce normal tissue complications, so that the radiation therapy is safe and always governed by justification and optimization. And radiation therapy could be used before or after surgery. You know that sometimes we need radiation therapy to shrink the tumor first, and then the patient can undergo surgery. Or after surgery, we can treat the tumor bed in partial mastectomy or complete mastectomy. Also, we can irradiate lymph nodes in order to reduce that, to ensure that all cancer cells were destroyed. So we can use before or after radiation therapy.
Thank you, Dr. Abdelmonem. Two more questions. One from Prof. Bushra.
I think yes, this is the last question, Prof. Bushra, because we run late now. We need to go to the second session. Please, go ahead. Go ahead with your question, Prof. Bushra.
Thank you very much, Mr. Chairman. Thank you. Of breast induced, cancer induced radiation that we know stochastic radiation have got long time to be detected. It needs a team to detect the long time effect. Stochastic effects are long time and not short time effects. One of them is cancer, and cancer acquiring sometimes in breast cancer patients is due to the incidence of cancer in one breast could acquire the second breast cancer. So if the patient life after acquiring the first cancer is between 5 years to detect induced cancer. Second question is, do you think the digital radiography is contributing to overdosing of patients and manipulation or manipulate outcome of the image density, brightness on the screen? I of exposing patients and then manipulating then they do manipulate the image. Do you think digital imaging is sometimes contributing to the overdosing of patients in medical radiation?
Thank you very much, Prof. Bushra. Prof. Bushra is my professor from undergraduate studies long time ago. I really appreciate joining him in this session. The first question, yes, I agree totally with you. Statistics showed that secondary breast cancer for patients received just surgery is 59 patients, while patients received radiation therapy and surgery was 73 patients induced radiation secondary cancer. I mean, that means the ratio from 59 to 73, just 14 additional cases. It is not very high risk, but still there is a risk. In general, when we compare the radiation risk with the benefit by increasing the half-life of the patient by 10 years, 15 years, so that this risk just, we can just ignore the radiation risk, but at the same time, we will do our best in order to ensure that the patient receives the best healthcare possible. The second question is very important, actually. Our experience in diagnostic imaging, that many, yesterday I reported a study we conducted here, that 80% of the mammographic procedures with normal findings. This is very serious issues, actually. That means the justification of the radiation exposure is not fulfilled precisely. Dr. Nawaf Abdullah said the ratio should be just 15% maximum. But here we receive that almost 80% of the patient with normal findings. That means we have to consider first the justification. And this number also consistent with the International Atomic Energy data said that 30 to 50% of medical exposure is unjustified.
Unjustified.
There is some issues, two issues. First, the issue of machine settings. Also, from our work in diagnostic imaging, always machines set by company applicator. I mean, when we purchase a new machine, the applicator always set up the exposure parameters and train the technologists. Always they use to convince the staff that we have the best machine ever to produce very high image quality. This high image quality always in radiography accompanied by very high radiation dose. The technologists use the same setting for all patients without any change. This is very obvious in CT scan and in digital imaging because, as you know, in diagnostic imaging, in digital imaging, the issue is about signal to noise ratio. So that the higher the dose, the better the image quality. This is the first issue. The second issue about justification is defensive medicine. Defensive medicine is common practice in all over the globe. I mean, when doctors use radiation for defensive reason, just to, he think about the court, about complications with the patient in the future. He said that I did the radiography and the radiologist said that it is normal. So I have no responsibility. This is common practice in different countries, especially in the United States and Europe. And I think in our countries, to some extent, also available. We need to educate people to protect themselves from ionizing radiation and to advocate why this X-rays is very important for me. Without, because we have issue also in our countries, self-referring. Patient insist for the doctor to order or to issue X-rays to make sure that he is normal.
He is satisfied.
Yes.
With the care he is getting.
Yeah. No.
Thank you, Professor.
Thank you very much, Professor Abdelmonem. Thank you very much.
We excuse Dr. Grain if the Dr. Amjad, she has the final last question.
Hi, Assalamu alaikum. Thank you very much, Prof. Abdelmonem, for your excellent talk. Do you know, Doctor, that many types of
Excuse me?
Are used in treatment for cancer.
الصوت دكتورة أمجاد. الصوت
دكتور.
الآن سامعينك، تفضلي دكتورة. الصوت فقط.
Thank you very much, Prof. Abdelmonem, for your excellent talk. You know that there is many types of radiation are used in treatment for many types also of cancer. But recently, medical institutes tend to use proton therapy for the treatment. Do you think it's good for use it for breast cancer treatment and can reduce also the risk of the secondary cancer? Thank you very much.
Yeah, thank you very much. This is a very important question. Proton therapy is the best choice for treatment or cancer. I mean, in physics, you know that the Bragg peak. In radiation therapy, for photon beams, we have to destroy normal tissues before we can reach the tumor. But in radiation therapy using proton therapy, we can reduce the radiation for the normal tissues at minimal amount, I mean 10 grays, for example, and increase the radiation dose for the tumor up to 80 grays. I mean, we can control the tumor completely in a very homogeneous way. And I'm very so happy that King Fahd Medical City, now they are building a new proton therapy center, one of the fewest centers in the world. Unfortunately, my colleague during PhD, he is going to commission the system I think very soon after coronavirus. The response to your question that yes, proton therapy can reduce the radiation risk for the patient and increase the tumor control probability to highest possible ever till now.
Thank you so much, Professor Abdelmanem, and for this valuable lectures. And now we will move forward for the next speakers. Thank you, Dr. Abdelmanem. Professor Bushra, he will be the next with us. Professor Bushra is head of department of radiation department in University of Hail. Go ahead, Dr. Bushra. تفضل. I think Dr. Grain has a technical issue, so do you hear me, Dr. Bushra, Professor Bushra? Professor Bushra?
Professor Bushra, you hear us? Dr. Mashari, Professor Bushra with us?
Yeah,
Professor?
Check. I think he disconnected now.
Okay, so we'll move to the second one, which is Salman Al-Baishan. So please join me to welcome Dr. Salman Al-Baishan. Dr. Salman Al-Baishan is Associate Professor at King Saud University College of Applied Medical Science. He specializes in breast imaging mammography. And he will give talk today about mammographic density distribution in Saudi Arabia across sectional study. Go ahead, Dr. Salman, if you hear us.
I'm very sorry. Okay, you've got somebody?
Yes, we.
I have been disconnected. I'm very sorry. Sorry for.
No, it's okay. Prof. Bushra, now we go with Dr. Salman, and we will go with you after him. Sorry.
Okay.
Immediately. Yeah, sure.
Okay.
Sure. Thank you so much. Go ahead, Dr. Salman. Dr. Salman, unmute, please.
Yes. Yes. Good morning, everyone. Thanks, Dr. Grain, for this opportunity again. Is the screen sharing is working? I believe yes. Okay.
Yes.
Okay. Today I'm presenting parts of my thesis, so I need to use this the same themes by university or recommended by University of Sydney. So this study mainly focused on mammographic breast density. First, I will give a brief background about what mammographic breast density, why it's important in the field of screening. We will go briefly on breast anatomy and then moves to walk you to mammographic breast density and the study objective, method, result, implication, limitation, and finally the acknowledgement. So in brief, women's breast consists of fat and dense tissue. The dense tissue, when we say dense tissue, it's related to the fibers, nipples, and the ducts that carry the milk. On mammogram, usually the fat looks black and radiolucent, which means allowing X-ray to pass, while the dense tissue looks bright and preventing X-rays to pass. In terms of the importance of mammographic breast density or breast density as a risk factor, the American Cancer Society, ASR, which is one of the well-known organization, mammographic breast density range in the middle. So it's between 2 to 4 as a risk factor. So women with extremely dense breast tissue has 4 to 6 times risk to develop breast cancer. Why there is a risk? From biological point of view, women with high breast density, there is a chance of DNA mutation, as much growing cell in the breast as increasing in the chance of DNA damage. From our perspective in radiology, increased breast density, just I will use the pen, increased breast density decrease the sensitivity of mammogram, which we know as a masking effect. The image on the B, shows a woman with low breast density, making radiologist easy to pick up the cancer. As mentioned by Dr. Fatina yesterday, missed breast cancer on women with high dense breast is high. The image on the A is the women with the dense breast. So it will be difficult for the radiologist to pick up the cancer. And as we know, breast cancer, it's a very tiny and in millimeters. The graph on the left shows the attenuation coefficient of the different tissues in the breast. So the adipose tissue compared with the breast tumor and fibroglandular, we can see that the attenuation coefficient of the breast density and the breast tumor, it's almost the same. Again, it's easy to pick up the cancer on the fatty breast. In the United States now, almost all states have legalized dense or what we say mammographic breast density notification law. So by law, the radiologist needs to notify the woman that she has dense breast, and it's her option to go for supplementary screening by MRI, ultrasound, or contrast enhanced mammography. So the objective of this study is to examine the distribution of mammographic breast density as presented by dense breast area or percent density, and to examine the risk factor related to the mammographic breast density among Saudi women for the first time. Okay, we collected data from Al Iman General Hospital and King Salman Hospital and Asir Central Hospital. The data was collected based on the availability, to be honest, and 650 women were recruited from breast cancer screening centers. So the data was mainly from Riyadh. In total, 902 was available for initial evaluation. Cases with oral consent form was deleted, along with the data or women with previous history of breast cancer. For evaluation, because we are using automated breast density measurement, masses larger than 5 millimeter were removed from the study, along with the missing images was found in 52 women. In total, 792 mammographic examination was ready to be analyzed. Before the survey, or before the mammographic data collection, the survey maybe consists of 10 or 13 close-ended questions was collected from the participants, including demographic data, reproductive data, along with the BMI was calculated immediately before the mammographic examination. In terms of the ways of assessing mammographic breast density, the most well-known used in the clinic is the visual assessment from 1 to 4, where 1 and 2 were regarded as low breast density, whereas 3 and 4 regarded as high breast density. This classification is recommended by ASR. So women with level 1 and 2 were regarded as low breast density. Women with level 4 and 3 were regarded as high breast density. We do have semi-automated. In semi-automated, where radiologists by the mouse, circle the area of he or she thinks this is the high breast density, and then the computer will calculate it for him. The latest innovations in breast density were the volumetric breast density measurement, which takes this, the Z direction into account. In this study, we have used fully automated, which means that the software will calculate the percentage of breast density along with the dense breast area. This software called the Laboratory for Individualized Breast Radio Sensitivity Assessment, LIBRA, which is developed by Breast Imaging Group at the University of Pennsylvania. This software is publicly available, so everyone can use it with the acknowledgement in the paper. So how the software works: simply when you ask the software to calculate the density, first it gives you a histogram, and then it gives you the histogram with the hotspots area where the software thinks this is the high breast density, and then it gives you a shadowing for the dense breast area. The outcomes for each image, it will be like that. It will gives you the breast area in total, and then the dense breast area, and the percent density when you divide the dense breast area by the breast density. For example, in this mammogram, the percent density was 21. Let's move to the result. As you see, the total was 792. Most of them were below the age of 50, so it's in the age of screening. Most of them were Saudis. Most of them were married, I believe, homemaker, have low educational background. The income, we thought that there might be some connection between breast density and income as suggested by previous publications, but we didn't find it here. Most of them were premenopausal. Interesting finding, and yesterday a lot of speakers have mentioned that obesity is the main risk factor for breast cancer. In this study, we found that most of the women, only 8% have normal or underweight, whereas most of the women are obese, extremely obese, and obese stage number 3. Again, the age of menarche, most of the women, below the age of 13 and above the age of 13, most of the women were parents. They have 5 to 8 children. The age at the first child, it's almost half of the women have delivered their baby before the age of 20, whereas half of them delivered after the age of 20. Most of the women have an experience of breastfeeding, and most of the women have not used oral contraceptive or have used hormonal replacement therapy, and most of the women have no previous history or family history of breast cancer. So in this graph, we show that the distribution of the items delivered by the software. For the breast area, it's clearly that the mean and median are normally distributed. However, for the percent density and the dense breast area, it's totally skewed because less women in our cohort have high breast density. In the data analysis, we do a univariate analysis and multivariate analysis. For univariate analysis, first we done a Spearman correlation between continuous variable, and then we do a Mann-Whitney and Kruskal-Wallis test for categorical variables. So in this table, we divide it into two. The first section shows the correlation between the age and the percent and the dense breast area and the percent density, and between the height, weight, BMI. All of these were well known in the previous publication. However, the age at Maniraki in this study shows a positive correlation with the both dense breast area and percent density. In previous research, some papers have found a positive correlation where others found a negative correlation, and it's highly recommended to do more study in this area. You can notice that the correlation is relatively weak, except for the BMI, and it's clearly that our results might be biased of the study cohort. In terms of education, we did found a positive or significant association between both dense breast area and the percent density. And we did do a post hoc analysis, and we found that the two groups that have the significant were between women with no formal education and the women with the higher educational group. For those with no background on the post hoc analysis, the post hoc analysis, what we do a several association, for example, between no formal education and women with the high school, and then no formal with a diploma, again between high school and the diploma, and the program or the SPSS gives you where the significance emerges. In terms of menopausal, it's well known that women with or premenopausal women, because they are in reproductive age, have more dense breast area and percent density. So to have more understanding on what's going on with our data, we did a binary logistic regression. First, let's move to the next table, which I believe it will be more easy to be understand. First, we did the baseline model, which include all significant variables. This was our baseline model. So the covariant that shows significance in the univariate analysis were included in the baseline model. So these are all significant variables that shows significant in both percent density and dense breast area. And we use sequential binary logistic regression when we enter each covariant alone. So first we enter the BMI, and then the age, and then the number of children, and then we didn't force all items together in one model. Then the items that show non-significant were removed, mainly speaking. The age at first child and education was removed because they didn't show significant, and then we only kept the significant model. And then what we mean by fully adjusted, we add the age, breastfeeding, and the use of oral contraceptive, because these covariants were found to be highly related to breast density, even though they are not significant, but we need to adjust it in each model, especially age, breastfeeding, and oral contraceptive. Now let's move to the R squared, which means that how many variation explained by these variable in the model. It's clearly that the BMI model alone explain half of the variant in dense breast area. So 7.7% of the variation in the model explained by BMI only. Again, this might be biased, because of the study cohort. A better improvement when we do the percent density model. The baseline model explains 17.8%. Again, the BMI model alone explained 12% of the variation in the model. The discussion or what we can learn from this study. We do have low breast density in Saudi women. That's the first significant result. This result have been supported by other studies conducted in women from Eastern region. If I'm not wrong, 2 studies conducted by Dr. Fatima Al-Mulhim showed that low breast density, very low breast density among Saudi women, which I believe it's greatly affected by increased BMI. If we see that US women, either white or in general population, including Hispanic and African American, and if we see the Chinese, Singapore women, it's almost a double. Now let's see the most significant result along with the low breast density found. As I mentioned previously, the age at Meniraki. Age at Meniraki was positively associated with both breast density and percent density. As I said, it's a conflicting result. Some people suggested that this relation is negative, while others suggested that the relation is positive. Our finding is supported by the recent large population-based study that examined mammographic breast density of more than 24,000 women between the age of 20 and 74 using semi-automated, which is almost what we used in this study, found the positive association. However, the author of this study highly recommended further and deep analysis for the association between the age at Meniraki and percent density. Again, it should be borne in mind that the proportion of dense breast density might be advantageous to go for additional breast screening. However, most of recommendation that comes up from international organizations say that women with average or low risk with breast density, mammogram will be enough. However, for women with high breast or with women in high risk group, along with high breast density, supplementary screening are highly recommended for those women. In terms of BMI, because almost 80% of the study cohort have high BMI, one might think that the increased BMI would be advantageous. So women or the breast will be fat and will be easy to pick up the cancer. However, data showed that compared with women with no normal weight, women with high BMI had almost 80% increased risk, not only for advanced stage of breast cancer at diagnosis, but also of poorly differentiated grade when the first diagnosis. So we suggested in this paper to facilitate early detection among Saudi women. By the way, this prevalence of increased obesity or this prevalence of increased BMI have been same in a national survey by Ministry of Health. So our study is reflecting the obesity in Saudi women. So we recommended to revise the mammography screening interval, especially for those with the high BMI, to be a 12-month screening interval, especially if the woman belongs to high risk group. And this is also been seen in European countries, particularly in Sweden. The limitation, as obvious, this is a cross-sectional, so the generalization would not be, applicable. Maybe a longitudinal one will be more suitable because the percent density have been seen to be changed throughout the time. The second limitation is the population were mainly from Riyadh, so we urge to do a national breast density measurement. In conclusion, we found that Saudi women have low percent density, and we suggest that they might not require additional screening. However, we need to do, risk assessment. And now there is an emerging idea of individualized breast screening based on the women risk. I would like to acknowledge all those people who helped me in the data collection phase during the data collection. And this paper have been published in Clinical Imaging, so you can go and read it in deep. And please feel free if you have any questions.
Thank you so much, Dr. Salman. It was a great talk. And the chair of this session, it will be Dr. Yasser Al-Zaman. Please go ahead, Dr. Yasser.
Thank you, Dr. Grain, and thank you, Dr. Salman, for the great talk. It actually shows interesting statistics. Actually, I had a chance to had a look to another study conducted as well by you and your colleagues. Is that right? I think in Ras Al Khaimah.
Yes.
Yeah. Both, I think, shows that Saudi and I think Emirati women's has low breast tissue density. The question is, do you think that's, or the cause or the reason is genetically or impacted by the environment?
Actually, the data say 30 to 20% of variation in mammographic breast density explained by reproductive factor only. So we do have 70%. There is a twins study of percent of mammographic breast density when they study for maybe 15 years. The twins sister showed breast density is highly, based on hereditary. So this is an area of investigation, particularly here in Saudi and in the GCC countries.
Thank you, Dr. Salman. Beside your recommendation for the high-risk group to do a 12 months screening, do you have any additional advices for people who belongs to this group regarding the lifestyle to reduce the risk?
A breast or mammographic breast density is one of the risk factor of breast cancer. So it's breast cancer. It's a multifactorial. So women needs to be aware for all of these cancer, and it's a long term. So, for example, after the or post-menopausal women, if they use hormonal replacement therapy, their breast density will increase. So the recommendation is multifactorial, based on the fact that mammographic breast density is one of the risk factors of breast cancer. Right. And I believe there is intercorrelation between these risk factors. For example, physical activity decrease both breast cancer and mammographic breast density.
Great. Thank you, Dr. Salman. I will see if there's any one have a question.
Yeah, there is no question, I think. Thank you so much, Dr. Salman. It was a great talk, and we are so glad and pleasure to be with us in this conference.
Me too. Me too. Thank you.
Thank you so much. It's a great job, Dr. Salman. Thank you so much. Now we'll go to the second speaker, which is our director of radiology department of Prof. Bushra Hussain. So Prof. Bushra is a professor and consultant of medicine and radiology. He's a director, head of radiology department, College of Applied Medical Science, University of Hail. He's a member of organizing committee and scientific committee for this conference. He is the Dean of School of Medicine and Radiology School over 15 years. He has long experience in radiology and medicine. He's current, so he published a lot of articles in high distinguished radiology journal. So go ahead, Prof. Bushra, you can share the screen with us now, please.
Thank you, Mr. Chairman. I'm very indebted to you for your.
Yes, the chair of this session will be Dr. Amjad. Is our Amjad Al-Yahyawi is our vice dean.
Okay. Thank you, Mr. Chairman, for giving me the chance to deliver this lecture, and thank you for introducing me to your audience. I hope all the best for this conference. I'm sure you will get through. We will get through, all of us, through this nice conference, and we will make benefit to our audience, being academic staff or our other audiences from the society or other related sectors of the society of Saudi Arabia. I will be talking about something which has been hammered on throughout the first day and this day, which is the BI-RADS system. This BI-RADS system has been established by the ACR, the American College, sorry, the American College of Radiologists. It has been meant to make a sort of jargon language common for the clinicians and reporting radiologists. And this will enable the radiologists especially to make brief description, and still, although it is brief and well-defined, but it will be more informative and will help in this way to communicate in very professional mean with the other colleagues. Although this BI-RADS has been established for the screening of mammogram screening for breast cancer, but it has been also adopted by the radiologists who are doing the same reports for MRI and ultrasound. We have benefits as radiologists, have benefits from using such well-defined and good description of the state of the patient breast. We will observe that there are some of the descriptions of these BI-RADS include range of percentages rather than sharp percentages. That because this has been drawn from different schools of studying and research of breast cancer for breast cancer imaging. Sometimes you find ranges, sometimes you find something which is stated as 1 percentage, but definitely we have the radiologists will benefit from this because they will be forced to put what they have seen from their mammograms into a well-defined term, which is the chain or series of the BI-RADS, which we are going to see in the coming slides. Also, it will help us or help the health system to calculate the statistical knowledge or statistical to infer the statistical meaning and prevalence of each of these BI-RADS each year, because the calculation of the statistics is done yearly, and this will help in maintaining quality assurance. we will have a positive feedback as radiologists for those who are doing the job properly or in a good standard, and those who are not. For those who are told to have good statistical calculation, they are going to go on doing the same job. But for those who are lagging behind slightly, proved by their statistics of reports, they will be advised to do more training on reporting the breast mammograms. Yesterday, it has been mentioned that some of the things are maybe missed. And today we have seen somebody saying dense breast has been put in the legislation of the Americans to protect the radiologists who are going to misdiagnose small cancers in very dense breasts. So I think we are going to use these terms to help us to do the reports, and those who are professional, they should do the job. If they get good statistics on their reports, then they're going to do their job. Those who are not should have do more training, because the responsibility is very high. Actually, it has this BI-RADS has or have the BI-RADS have standardized our language and words of report, and they have reduced the confusion between the reporting radiologists and the physicians. It also, these statistics and the piled data will help us in promoting our research on breast cancer. The BI-RADS set by the ACR starts with 0 and ends up with 6. 0 means incomplete, 1 is negative on mammogram, nothing has been subnormal has been detected, and 2 benign findings were seen on the mammogram, probably benign for category 3, and 4 is suspicious abnormality seen on the mammogram. There are some areas which are suspicious. 5 greater than, there is a high suspicion of malignancy, and 6 is a grade of given assigned to those who have done biopsy and proved to be, the lesion has been proved to be malignant. So this quite briefing of the BI-RADS will help us very much to categorize the breast lesions. Going from 0, 1, and 2, and 3, you see all of these 0, 1, 2 are lying within the benign or no lesions. And from 3, 4, 5, we are getting into the zone of malignancy, probably at BI-RADS 3 and 4 and 5 more suspicious. So after screening, we need to do diagnostic mammogram. This should be recommended for BI-RADS of grade 3 and above, 4 and 5. Majority of cases done through the screening will be usually is reported to be lying within the BI-RADS 1 and 2, and most of the women coming for their annual mammograms will be assigned or could be assigned BI-RADS 1 and 2. The positive predictive value for breast cancer incidence in the BI-RADS or at BI-RADS category 4 will take us to the gray, or not gray, actually reddish area of warning that we are getting into the zone of getting, probably getting cancer. But during screening, it is being found that only 9% of all the cases being screened are within these 4 or 5 categories. Only 9% only lie within 3, 4 BI-RADS categories. So 0, 1, 2 are out of the range of being suspected to have anything which is related to cancer. As we move from 3 BI-RADS 3, we get to have more attention and more interest, and to be more keen in getting this patient problem being resolved, either to overrule it as benign or to go into other procedures to prove that it is not, and the patient should be selected for the proper follow-up or proper procedure. And this is actually the role of the BI-RADS. It helps us not just to form a good report in good words, which is highly selected and very meticulous in describing the breast lesion, but also it helps us to plan for the next step of either imaging or other procedures like biopsy. BI-RADS 4 and 5 are always getting us or leading us to the area of biopsy. 3 has a low predictive value for cancer, usually lying within 2%. 4 has a predictive value for cancer lying within 30%. Sometimes you see it as ranging from 20 to 40. And category BI-RADS 5 mammogram has a risk factor of, or a risk of getting a cancer lesion by 95%. Category 0, now we go through these categories again because we want to say and to see something about what does it mean and how it is going to be dealt with and what is going to be done between the radiologist and the clinician. Grade 0 is incomplete. Either we haven't got more information about his prior exams and or we need to do more steps or more checkups to get into the definite about there is no abnormality. So we might need to go further for spot compression imaging of mammogram, or do magnification, or do ultrasound, or and wait for the prior exams to see if there is any change from the previous record. So if a lesion, a round lesion, smooth looking like a cyst, has been seen and the patient has done a mammogram, the radiologist will assign BI-RADS 0 and will send the patient to do ultrasound to confirm his findings. If the patient turns up to find with the report saying there is a benign definite cyst, then the radiologist will assign category 2 for this case and will change from category 0 to category 2, in which we have said that the lesion is definitely benign. This is briefing of this finding of this category. The category is not complete, and the patient has to be asked to either avail the previous information or proceed to do extra imaging of, as we said, with compression or magnification or ultrasound. And the likelihood of breast cancer for this category is NA. There is no possibility of any cancer because we said that there is nothing being seen and the information completed and proved that there is nothing than what we have already seen. Category 1 is negative, definitely negative, without needing any help, because we have already moved from a state of category 0 to state of category 1. That means that the information is available, the patient is available, and we are trying to do the mammogram. And in this mammogram, we should assign category 1 because we haven't seen anything. There is no microcalcifications on our radiograph, no well-defined or formed mass seal, and there is no asymmetry or structure, and or there is no changes from the previous exam, as we have said. So to brief this category, this category revealed a negative examination on routine screening, and the likelihood of breast cancer is essentially 0. Category 2, in this category, we will have definite benign lesion on our routine screening. Has been seen on this mammogram is definitely not a cancer or malignancy in any way. Like these microcalcifications we are seeing here, precipitated like or sediment like or leaves in teacup like is a benign finding. And the one beneath, as you could see, is just a small microcalcification, rounded and smooth, and it resembles actually a benign, definite benign lesion for category 2. BI-RADS 2 findings may include round opacities like with microcalcifications, but as we have seen, calcified fibromas or something like that, round opacities like typical of a cyst on ultrasound, oval opacities, and this sort of fatty, partially or completely, surgical scars, scattered macrocalcifications or fibroadenomas or vascular calcifications or breast implants of silicone. So the features are quite spoken out or clear that the lesion is quite benign, definitely benign. So category 2, the lesion is benign. Routine, you proceed just for routine screening. The patient has nothing to do else than just this routine screening, and the likelihood of breast cancer is. Category 3, we are getting into the gray zone between the white and the black, or the green and red. So for category 0, probably benign. With BI-RADS 3, the radiologists will recommend a follow-up at a shorter interval, because the mammogram is done 2 yearly or 1 yearly, and then now we are calling the patient back after 6 months to make sure that the lesion is benign, hopefully. The lesion is not palpable. If you see a lesion which is not quite clear, it is benign, it is probably benign on mammogram, but usually on clinical examination, it is not there, it is not palpable. That means it is a very small, well embedded, maybe deep in the breast, and very small. For benign lesions like fibroadenomas, they sometimes get a very funny name. They call it the mouse of the breast, because sometimes you touch it here and it escapes to the other side. And maybe it is difficult to palpate a small fibroadenoma, like, for example. Findings of this category includes clusters of tiny calcifications, non-calcified solid nodules, round or oval, and well-defined, selected focal asymmetrical areas, or fibroglandular densities, miscellaneous like focal findings, like post biopsy or scars and this sort of things, or generalized distribution in both breasts. So doing both sides is helpful to help you to get the symmetry of the densities distribution. These are the features of these similar lesions. It is diffuse, punctate microcalcifications in the breast. You can see it. Features are not suggestive of malignancy, but the fuzzy one down there was seen on a patient who was supposed to be category 2, but found the microcalcification showed fuzzy and indistinct boundaries and has been assigned category 3. So just one feature like this fuzziness will put the patient into a system of rechecking again and again, and to make sure that it is not a cancer. Positive predictive value of category 3 is actually low, and experience and researches have proved that it is even less than 2%. We mentioned earlier, it lies between approximately 2%, but with experience and researches, it has been proved that category 3 incidence of cancer is less than 1%. But later on, we will see how we get into regions. We say it is less, greater than 0, but going up to 10, as you could see, or you will see later in this presentation. So the category 3 is probably benign. The patient needs to be recalled for a mammogram in a short interval, or to continue if it is not strongly being proven, the suspicion is not high, then he can go for, or she can go for continued surveillance. The likelihood of breast cancer existence in this category is greater than 0%, but less or equal 2%.
Prof. Bushra,
Yes.
please, if you don't mind, just finish within 3 minutes, please. Thanks.
Again, please.
3 minutes, please. More. Yeah.
Okay.
Because thank you so much. I know it's an interesting topic, but we need to go to another speaker because we are here. Thank you so much. Yeah.
Okay,
Within 3 minutes.
Thank you. Thank you, Mr. Chairman. Category 5, category 4, sorry, suspicious or indeterminate. In this birat, the risk increases and biopsy is usually recommended. Biopsy should be recommended for patient actually of the 2 categories, 4 and 5. This birat or BIRAS 4 has been subcategorized into 3 subcategories of 4A, 4B, and 4C, and the likeliness of malignancy goes to lower, moderate, and high as you go through 4A, 4B, and 4C. I will just mention some of these asymmetries or the suspicious areas of asymmetric in the or localized, evolving hyperdensities in the breast, or indeterminate microcalcifications, or amorphous or heterogeneous polymorphic densities or calcifications, round or oval, non-cystic opacities. These are the things to be seen in this category. As you see here, this is a Bowdrich calcification describing BIRAS 4. The second image is of a cluster of large size of the same Bowdrich calcifications. BIRAS 4 has a quite high positive predictive value for cancer, and we can go directly to the sub divisions of 4. 4A has the lowest predictive value, which is 13% here. B is 36%, and 4 is 79. Most of the changes in the category 4 are fibrocystic changes, but we could have other changes like DCIS and fibroid. The existence or the prevalence of the fibrocystic disease or lesions in the breast category 4 for fibrocystic is 20% existing. DCIS is 23%, and fibroadenomas is 19%. DCIS itself can be subdistributed or distributed along with the subdivisions of 4 into category A. DCIS is 10%, and in B it is 21%. In C it is 70%. So as you go from 4A, 4B, 4C, the likeliness of getting cancer is increasing. The frequency of these ABC subdivisions of 4 come in the surveillance as in A we get it 50% of the cases are of category 4 are in A, and 38 in B, and 13 in C. Category 4 is suspicious. Tissue biopsy is suggested, and on the right side you could see the percentage of how much malignancy you are predicting in the subcategories. Category 5 is more suggestive of malignancy, and also tissue biopsy is needed. The findings is this in this category is typical microcalcifications, malignant microcalcifications, clusters, evolving microcalcifications, and poorly circumscribed obesities with ill-defined and irregular contours. These are BI-RADS 5 with the patterns of classification we see, like the linear ones, as you could see, the fragmented and the branching one, which is quite suspicious of being malignant. In category 5, actually, the predictive value is 95%, and when biopsy is done, the rate goes between 75 to 90% to 95%. Sorry, from 75 to 97%. The branching glandular microcalcification is highly suggestive of breast cancer. So in category 5, it is highly suggestive of malignancy. Management is tissue biopsy, and the likelihood of breast cancer is greater or equal to 95. In category 6, we are approximately coming to the end of the session, so don't worry. In category 6, the case has been proved to be malignant by doing biopsy. This category has been assigned for biopsy-proved cancer, and it remains even during treatment and years after. This category does not need to fit in one of the previously mentioned BI-RADS from 0 to 5 because it has been assigned 6, and this 6 has no statistical benefit. When we mention it in our reports, we are not going to be considering it in our statistical calculations. These are, I won't go through this. These are patterns of some classifications which has direct relationship with existence of cancer in the breast, heterogeneous densities, amorphous, microcalcifications, fine, polymorphic, and fine, linear, and branching. These are all suggestive of malignancies with the percentages put against each one. I will go to the end of the briefing of this slide. Category 6 is biopsy proved malignancy. Surgical interference is the management needed whenever or whenever clinically applicable or appropriate, and the likeliness of cancer is already there, so there is no prediction for another cancer over what has been mentioned as cancer. It is okay. Thank you very much.
Thank you so much, Prof. It's a great talk and interesting topic. And Prof. Abdelmonem, if you have just please one question before we go to the second session, please. Do you have any question, Prof. Abdelmonem? Okay, I think we we will move. Sorry, Dr. Jaili, because we are late. So now we will go to the second speaker, which is Professor Anwar Abdi Jaid. He will talk today is about role of physiotherapy, role of updating physiotherapy breast cancer rehabilitation. So he's a professor from Al Qura University College of Applied Medical Science. So we will go with the Prof Anwar, and if we have a time, we can go with our colleagues Leo and Dr. Shahnawaz. Otherwise, we can shift them to after break. So go ahead, Dr. Anwar. Sorry for late. And as you see, all of you, it's interesting topic, interesting talk, and we couldn't interrupt the people, so we would like to give a chance. And as we know now, it's online. Everyone, they can go and take rest and relax. So it's not on-site conference. So much appreciated for your consideration. Thank you so much. Go ahead, Prof. Anwar. So the chair of this session, it will be Dr. Leo. Thank you so much.
Hi, everyone. Today I'll talk about the latest update in physiotherapy breast cancer rehabilitation. First, I would like to thank Dr. Karim Shamari for a kind invitation, and I also wanted to thank all audience in this conference and the member of IT. Today I'll talk about the latest update in physiotherapy breast cancer rehabilitation. First, the content includes the following: introduction about breast cancer, guidelines in breast cancer rehabilitation, successful outcome of initial management, and latest update in breast cancer rehabilitation. This is according to American Cancer Society guidelines from 2016 to 2017, and Society of Integrative Oncology and the Guidelines Working Group, and published the randomized controlled trial and systematic review article from 2019 until now. Our objective, the main objective of this lecture is to clarify the latest update in breast cancer rehabilitation and the guidelines for treatment in relation to lymphedema, exercise, and electrotherapeutic modalities used in breast cancer rehabilitation. Introduction. Breast cancer is the most common cancer affecting women over 35 years, and survival rate of women after breast cancer has improved significantly worldwide due to widespread recent updated evaluation and assessment and treatment. The latest guidelines on breast cancer are clear now to some extent about the rehabilitation and the complication after surgery. Introduction. There is the need to strengthen the level of evidence of many commonly used clinical rehabilitation practice and to better describe rehabilitative approaches for breast cancer survivor according to the literature review, or according to the randomized controlled trial, or according to the systematic review. Here there are 7 breast cancer guidelines in rehabilitation for survivor patient in the latest 10 years. The physiotherapy approach for cancer rehabilitation involve the treatment of many conditions or problems associated with breast cancer patient. First of all, the upper limb impairment, which include the shoulder joint and hand, and the relation between the activity of the patient, also the relation between the hand and the shoulder impairment. The second is the range of motion impairment, most commonly of the thoracic area and the shoulder region, and upper limb region, elbow and hand. Postural imbalance, this is one of the most problem associated with after surgery, just due to tightness of the muscle or due to imbalance between the muscle in the front of the shoulder and the posterior aspect of the shoulder. Also, lymphedema, this is the most common problem, or long-term problem described in post-mastectomy patient. The second is the fourth one, or the fifth one, is the post-mastectomy pain syndrome. This term is developed after many trials or conducting many trials. There is a long-term pain associated with post-mastectomy patient. Also, shoulder morbidity. This includes the flexibility of the shoulder, decreased range of motion, and the muscle imbalance and decreased muscle strength around shoulder joint. Also, fatigue. This is a common feature in breast cancer patient after surgery. Our rehabilitation goal is to encourage and appropriate recovery of activity of daily living after breast cancer surgery, and prevent and alleviate adverse treatment outcomes and promote quality of life. This is the main target of our rehabilitation goal. What are the successful outcome of initial management? Our management or rehabilitation, the successful outcome of this point, of this term, is to reduce the volume and size of the upper extremity, to improve skin condition, improve subcutaneous tissue consistency, improve limb function, improve limb shape, improve symptom control, and enhance patient family, career involvement, and self-management skills. This is this terms should be included in our outcome of rehabilitation. The first long-term problem is lymphedema. Breast cancer-related lymphedema is a chronic and distressing condition that's estimated to affect about 13 to 49% of women who undergo surgical removal, or vessel node extirpation or removal, or radiation therapy. What are the secondary problem related to the lymphedema itself? The lymphedema is a secondary problem, or the secondary lymphedema is a main problem after breast cancer. And this lymphedema also can lead to other secondary problems, which include the following: functional impairment, reduced self-esteem, distorted body image, depression and anxiety, problems with sexual, family, and social relationships. What are the interventions used for treatment of secondary lymphedema? Include many type or many modalities used for treatment of lymphedema, which includes the following: intermittent pneumatic compression therapy, complete decongestive therapy. This is most commonly used nowadays for all lymphedema patients, manual lymphatic drainage and self-massage, compression garment or sleeves, compression bandaging with a moderate compression or pressure, low-level laser therapy, and hyperbaric. This is some questions about the use of low-level laser therapy and hyperbaric oxygen therapy, but it is nowadays there is an evidence for use of low-level laser therapy in treatment of secondary lymphedema and also the hyperbaric oxygen therapy. And the main part of this treatment is exercise, movement, and elevation. Lymphedema treatment decision in relation to the physical therapy or physiotherapy approach. The best practice management of lymphedema is a holistic or multidisciplinary approach, which include many items or many modalities used with each other at the same time, which includes the following: exercise, movement, elevation, to enhance mainly to enhance lymphatic and venous flow, swelling reduction, this is main important point, and the maintenance to reduce limb size or volume and improve subcutaneous tissue consistency through compression and or massage, and to maintain improvement. Also, pain and psychological management, and to how to decrease pain post-operative, to allow more breaths functional ADL activity or improve quality of life after breast cancer surgery. Also, swelling reduction is achieved through the following. The treatment in breast cancer patient should be a multidisciplinary, not a single line of treatment. The combination of compression, which include multi-layer lymphedema bandaging and or compression garment, exercise movement with or without lymphatic drainage or lymphatic massage, manual lymphatic drainage, simple lymphatic drainage, and intermittent pneumatic compression. Maybe include most of the line of treatment with each other to reach the optimal improvement in cancer patient. Intensive therapy, or and sometimes it's named complete decongestive therapy. Complete decongestive therapy or complete decongestive therapy is a decongestion or removal of the excess fluid formed in the upper limb most commonly, and shifting this fluid to the healthy side or to the other side to remove the excess fluid in the upper limb mainly. This involves the following. Intensive therapy is multidisciplinary also, involves skin care, exercise, movement, elevation, manual lymphatic drainage, multi-layer lymphedema bandaging with inelastic bandaging. The sub-bandaging pressure most commonly used in literatures about 45 millimeter mercury. These procedures should be undertaken daily, at least one time per day. The intensive therapy program are likely to be undertaken for a period of about 2 to 4 weeks at least. The multi-layer inelastic lymphedema bandaging, it is a key element of intensive therapy regimen. For some patients, also may also form part of their transition, long-term or palliative management. Elastic bandage, the main function is to maintain a more constant resting pressure. As this picture show, the bandaging maintaining the resting pressure, which mainly decrease the shift of fluid outside to be collected under the skin. This figure shows the spiral bandage with the inelastic bandage. This is a multi-layer bandage.
bandage.
نعم. This is a spiral bandage or a multi-layer or elastic bandage. This is a multi-layer bandage, which involve the whole upper limb also until the end of the finger near to the nail. Intermittent pneumatic compression. This is an electric device. It is form part of an intensive therapy regimen or long-term management in selected patients. The intermittent pneumatic compression consists of an electrical air compression pump. It's a pump attached to an inflatable plastic garment that is placed over the affected area, which introducing a sequential pressure. This sequential pressure from distal part to the proximal part, which maintaining the limb size or decrease the limb size and shifting the fluid from the peripheral part to the proximal part. The garment is inflated and deflated cyclically for a set period, usually about 30 to 2 hours. The pressure may be used about 30 to 60 millimeter mercury, which is advised for this kind of patient. Or the pressure may be can be decreased to in some palliative care or palliative cases, or some precaution with some precautions. The low pressure also advised in palliative care about 20 to 30 millimeter mercury. The duration of treatment and the frequency about 30 minutes to 2 hours daily is recommended for the patient. Also may be used more than one time at day. Manual lymphatic drainage. The manual lymphatic drainage is a gentle manual lymphatic drainage is a gentle massage. The patient can do this massage by himself. That's recognized as a key component of decongestive therapy. Manual lymphatic drainage also encourage the fluid away from the congested area by increasing the activity of normal lymphatic and bypassing ineffective or obliterated lymph vessels. Compression garment. The compression garment is nowadays used in long-term management of lymphedema, most commonly following a period of intensive therapy. Used as a prophylaxis or as a part of initial treatment, it provides the only form of compression. The patient wears the garment during walking our day or for exercise only, or up to 24 hours per day. The garment should be replaced every 3 to 6 months or when they begin to lose elasticity. This is a form of constant compression or long-time compression or long-duration compression to decrease limb volume or limb size. Hyperbaric and laser. Hyperbaric, the main concept about the hyperbaric oxygen therapy, which improve lymph flow and reduce limb volume. Also, the low-level laser therapy has shown a potential for treatment of lymphedema, particularly of the upper limb, where it has reduced limb volume and tissue hardness. Exercise, movement, and elevation. Exercise, movement, and are a common rehabilitative intervention used nowadays to reduce edema or reduce lymph edema. The effect of exercise includes the following: improve muscular strength, cardiovascular function, which is very important for lymphedema patient or for post-cancer patient, psychological well-being, and functional capacity. Gentle resisted exercise stimulate muscle pump and increase lymph flow. Aerobic exercise increase intra-abdominal pressure, which facilitate pumping of the thoracic duct, which mainly as a main part of decongestion of the upper extremity. Combination of flexibility, resisted exercise, and aerobic are beneficial in controlling lymphedema. Pain as one problem, our main problem post-mastectomy and neuropathy is a common during and after breast cancer treatment with a prevalence between about 40 to 89% after breast cancer. This is a long-term effect of pulsed high-intensity laser in management or treatment of post-mastectomy pain syndrome, a double-blind placebo-controlled randomized trial. The conclusion of this paper is improve the pain intensity, also the pain decrease to the latest point, and the ADL activity and quality of life of the patient is improved in this study. This is a controlled randomized study. What are the recommended physical therapy intervention used for treatment of pain? May be used transcutaneous electrical nerve stimulation. This is in the literature. The bed bath and walking support, positioning, instruction, energy conservation strategies. This is very important. Acupuncture may be used also for treatment of pain, acupressure, and occupational therapy consultation for decreasing pain. Upper limb or postural dysfunction or upper limb limitation, the primary care in clinicians support or advice to assess the musculoskeletal symptoms, including pain, most commonly post-operative, offer acupuncture, physical activity, physical therapy, or rehabilitation. Upper limb limitation and postural dysfunction, the guidelines which is nowadays accepted and updated is American Cancer Society Breast Cancer Rehabilitation Guidelines, which specify that first, bilateral upper extremity function should be assessed preoperatively to assess the muscle power, range of motion, flexibility of the joint, hand function. Also, the physical therapy should begin on the first post-operative day with gentle range of motion exercise and encourage the first week after surgery. In relation to the upper limb limitation, also active stretching exercise begin in the first post-operative week or a drainage removal, and should be continued for 6 to 8 weeks until to 12 weeks, or until full range of motion is achieved, and it is also useful to instruct patient in scar tissue massage. This some form of exercise can be used, which using sandbags or using weight lifting, underwater exercise, very beneficial for the breast cancer patient. Also, this could give improvement in ADL, quality of life, and psychological well-being. Also, the TheraBand can be used for movement of shoulders in all directions, flexion, extension, abduction, rotation. Also, the ball, which is main important aspect of rehabilitation or treatment of post-cancer patients. Stretching exercise very beneficial for maintaining the length of the tissue and to maintain the range of motion and improve the flexibility of the muscle, including also stretching, TheraBand exercise, and weight bearing exercise or ball exercise. In upper limb limitation and postural dysfunction, between the 4th and 6th post-operative week, we go to or progress to the resisted exercise, which can begin with lightweight and proceeding to heavy weight. It is important to minimize the risk of infection and secondary lymphedema by advise proper caring for limb skin, minimize the extent of axillary dissection, avoid trauma to the arm, avoid body weight gains, vaccination, and venous bites, avoid intravenous access to axillary dissected upper extremity. The physiotherapy advice for early and better recovery after surgery, for psychological support and lifestyle modification, or recent guidelines emphasize on importance of maintaining healthy lifestyle, maintain body mass index less than 30. Body mass index above 30 represent a risk factor for the onset of secondary lymphedema. Weight gain has a negative effect on functional prognosis, so it is important to discourage weight gain, encourage the maintenance of lean body mass index, and offer a nutritional consultation if needed. The recent guidelines about the exercise, the long-term regular, moderate to high aerobic physical activity is associated with favorable prognosis. Aerobic exercise and weightlifting don't contribute to the development of lymphedema and improve muscle power, positive result in quality of life. The American Cancer Association guidelines recommend at least about 150 minutes of moderate exercise or 75 minutes of vigorous aerobic exercise each week, muscle strengthening exercise at least 2 days a week, which stimulate reinforcement in women who have treated by adjunctive chemotherapy or hormone therapy. Fatigue is a commonly observed symptom, particularly among radio and the chemotherapy patient. The recommendation about the fatigue encourage the patient to engage in moderate intensity physical activity during and after treatment, including walking, cycling, resistance exercise, or combination of aerobic and resistance exercise for 30 minutes most day of the week. To improve the quality of life, some guidelines which include stress management, grade 3, plantar reflexology, mediation, and mystellotherapy, yoga, which include the standard yoga or yoga practice for sleep disturbance. Also, the acupuncture have a beneficial effect in psychological and the quality of life of the patient. Finally, we note among non-pharmacological intervention, laser therapy, electrical stimulation, indigenous microwave therapy, and thermal therapy are not recommended due to insufficient evidence to support the use of it. But nowadays, there is a recent research articles, randomized controlled trials concerning the beneficial effect of laser therapy and low intensity and pulsed high intensity on post-mastectomy pain syndrome function and quality of life of cancer patients. Therapeutic ultrasound also it's absolutely contraindicated in used for the post-operative patient. And thank you for listening and any questions.
Thank you so much, Prof. Anwar. It's a great talk in physiotherapy, and you give us a good feedback about all technique it used for breast cancer rehabilitation. So the chair, Dr. Leo, please, if you have a question.
Thanks a lot, Professor Anwar, for this informative presentation.
Many thanks.
Yeah. You have insisted on the physical activity of moderate intensity, which can improve the quality of life and ADL and make the patient fit to live. I have few questions, Dr. Anwar. The first one is, as you have told, the active rehabilitation has an advantage over the passive rehabilitation, such as the modalities or maybe passive exercises. Can you give your views on this?
About rehabilitation, we should emphasize on active rehabilitation. Also, the patients should be included in a home program because the passive treatment nowadays is not preferable for engaging the woman in her life. So we will advise the patient to engage in a home program, and the routine physical therapy program should be advised also, and the rehabilitation center should be emphasized on the home program plus the standard program for treatment or for rehabilitation of patient. So in activity of daily living should be encouraged at home, exercise in fresh air, also the hydrotherapy or underwater exercise, very helpful for the cancer patient.
Great, Dr. Anwar. The second one is, when I was searching about the topic, I found the effect of kinesiotape over lymphedema. Can you tell a little bit about this? Is it really effective?
Sorry, Doctor, you can raise your voice a bit?
Yeah. The role of kinesiotape on reducing the lymphedema.
In the latest literature about the effect of kinesiotape, there is no more literature about the effect, but there is some selected articles published in latest year concerning the effect of kinesiotape is ineffective. But here I wanted to concentrate the guidelines which is approved by many researchers. The kinesiotape is one of the methods used for decreasing the edema, most commonly, and many patients improved by using the kinesiotape.
Yes. And regarding the psychological aspect, you told the patient with breast cancer, they have depression and anxiety. Even yesterday, the doctor of psychiatry also mentioned about this. So yes. Can we have some group exercise of having cancer patients together and they can do the exercise together?
Yes. One of the main effect of the psychological state of the patient, which lead to many physical dysfunction. If we improve the physical function of the patient, this improve the psychological state of the patient. So we concentrate in when treating the cancer patient in this aspect of treatment, and we should emphasize the activity and to change his lifestyle, or not to go with the psychological state, which may affect the physical function. Also, the exercise itself has a beneficial effect on psychological state of the patient, according to many literatures concerning the exercise rules.
Thank you so much, Dr. Anwar. It's a great talk, and I think we finish. I think, okay, Dr. Ali Al-Mijrad, please, a quick question, because we need to go to break time. We have a poster presentation. Just quickly, please.
Thank you, Dr. Karim.
Yes, thank you. We have a question from Dr. Al-Mijrad. He would like to ask, Associated Professor Ali Al-Mijrad. Yes, yeah, it's unmute from your side, Dr. Ali, please.
There is just only one question regarding the effect, how to measure the effect of physiotherapy on the patient, because maybe there is some negative effect on the patient. How can you measure the effect using the equipment for physiotherapy?
In treatment of any patient, which type or any case, you should first to do good assessment and describe in the problem list in detail. And you should begin by a chart which indicate what the what are the decrease in range of motion, muscle strength, upper limb flexibility, lymphedema or size of the limb. This is should be reassessed again to denote what are the effect of your exercise or your program of training. First, we should good evaluation. Second, re-evaluation. If you note any adverse effect, this is mentioned by the patient or your assessment also. You can make maybe no improvement in the function of the limb or no improvement in the lymphedema. You should again to reassess and redesign your program.
Thank you so much, Dr. Anwar. Thank you so much, Dr. Ali, for question. I think we get now the end of the morning session. Before I go to poster presentation, I do apologize, Dr. Shahnawaz, we don't have time. Is anyone have a question for a previous speaker, Prof. Bushra? Yeah, speak, Dr. Shahnawaz. Yes.
Are you asking me to, Mr. Chairman? Hello.
Yes, Dr. Prof. Bushra, because some staff they raised their hand, they would like to ask you before. So before we go to break, ask Dr. Al-Jaili. Yes, Dr. Al-Jaili, open the mic from your side, please. Because they sent to me, they would like to ask you before go to break, please.
Okay.
Thank you. Yes,
Thank
Dr.
Assalamu alaikum.
Alaikum salam, Dr. Jaili.
Hello, Ahlan, Dr. Bushra. Thank you for a very nice topic. I want to ask for BI-RAD category. BI-RAD 1, BI-RAD 2, BI-RAD 3, 4, 5, 6.
Yes.
There is a specific standard to identify this BI-RAD 1, 2, 3, 4 or according to the finding of mammography or ultrasound or combination mammography and ultrasound and history of the patient. How can I say frankly this for BI-RAD 0, 1, 2, this benign already, but the confusion BI-RAD 4, 5, 6. I can say frankly this BI-RAD 4. How can I say this? According to finding in mammography and ultrasound, or according to or combination with patient history and finding?
Actually, this has been assigned only for. Thank you for your question first. This scheme of terms has been assigned for the mammogram. So the description started with the mammogram first, and accordingly it has been promoted to do ultrasound and MRI. For ultrasound, as I could recall, there are certain other criteria. For example, the Japanese have got the height, width, size of the mass. If the mass is broad or the width is greater than the height, it is likely to be benign. It is not similar to the one in the mammogram, but the findings which are giving high score go from, for example, if there is no any lesion, then this is 1 negative. If there is a lesion but is benign, this is 2. If you find a cyst on ultrasound, it is 2. If you find a lesion which is likely to be slightly suspicious, not fulfilling the whole scores of getting malignant, then you will put it as suspicious and give it category 3. If it is moderately suspicious, then you go to 4. If it is highly suspicious, you go to 5. If it is definitely has been scanned before and proved to be malignant, you give it a score
or by RAT6. So you accompany the mammographic appearance to the ultrasound score with you. It's starting with zero, the information is not complete. You have to complete the information of the patient, especially the previous examinations. And then if there is nothing, nothing in the breast, then it is 1. If there is something which is quite benign, adenoma or cyst, it is 2 on ultrasound. And so you go on with the suspiciousness up to 4, 5, and then 6. The same thing can be related to ultrasound.
Okay, thank you very much.
Thank you so much, Prof, for the question. I do apologize. If anyone would like to ask, you can ask all presenter during any time by chatting. They will reply to you. I would like to thank Prof. Bushra and Prof. Anwar, the last 2 speakers. They gave great presentation and information. So now we have a break. So sorry for delay. The Dr. Leo and Dr. Shahnawaz will be present after 1 o'clock. So just for 10 minutes each one of them. And now we'll go to poster presentation, appearance on the system. And we have another committee. They will start now to evaluate the poster presentation for the conference. Thank you so much. Thank you so much for your time and your.
Thank you, Mr. Chairman.
Yes, thank you so much. Thanks. Assalamu alaikum. Thank you so much. Now we are coming back. So we will go for the 2 session in physiotherapy with excellent doctors, Dr. Leo. Just give me the slide of Dr. Leo, please. Thank you so much. Thank you so much. And we come back now, and we will go now with Dr. Leo. He's the next speaker. He will talk about the role of physiotherapy in prevention and management of lymphedema in post-operative breast cancer patients. So Dr. Leo is working as a faculty member in the physical therapy department, College of Applied Medical Science in University of Hail. He has more than 18 years of teaching as well as clinical experience in the field of physiotherapy. And please join me to welcome Dr. Leo. Go ahead, Dr. Leo, the chair of this session. It will be Dr. Shahnawaz to give us just a question and summarize of the presentation, if he could. Thank you so much, Dr. Go ahead, Dr. Leo.
Yeah, thanks a lot, Doctor, for the introduction. Can I share the slide?
Sure, please.
Assalamu alaikum and good afternoon to everyone. First of all, I thank the organizing team and the overall chair, Dr. Grine, as well as the chairperson of the scientific and the organizing team for inviting me for this presentation. Special thanks to Professor Anwar because he made my job easy, because I'm going to talk about the role of physiotherapy in the prevention and management of lymphedema, especially in post-operative breast cancer patients. So I'm going to talk about the secondary lymphedema.
Just enlarge the.
Is it okay, Doctor, now?
Yes, it's fantastic. Yeah, go ahead. Go ahead. Thanks.
So these are the objectives of my topic. So without wasting the time, we will move into the topic. What is breast cancer? As most of the experts, it is the major public health issue and the most common global cause for cancer-related death in female. And we all know this is the second most common form of cancer. And the increase is about 2 million new cases, which is documented in 2018. BC survival rate has been improved thanks to the technology and the improvement in the medical science over the past 20 years. So the survival rate has been increasing by about 1.4% annually. We have 5 standard treatment options for breast cancer, as most of the experts talk about. The first one is the surgical removal. The second one is the radiation therapy, followed by hormonal, chemotherapy, and biological or targeted therapy. This is used in different combination and sequences based on the patient's need and the disease. What are the complications of surgery? The most common post-operative complication is secondary lymphedema, and the incident rate is being varied between 5% to 83%, which has been documented by different researchers. After axillary lymph node resection, when we call this as a secondary lymphedema, if there is a 2 centimeter increase in the upper arm circumference when compared to the normal, or maybe when compared to the contralateral side. For example, if the right side they had a surgery, if there is a swelling which is about 2 centimeter more than the left arm, then we call this as a secondary lymphedema. Most women, that is about 71%, develop secondary lymphedema within 12 months after this surgery. 1 out of 5 women who has been treated with breast cancer develop lymphedema in the upper extremity. And the rate varies starting from 20% in the first 6 months, and it is getting increased to 36% in the first year, and keep on further increasing to 54% in the following years, that is about after 36 months. When this secondary lymphedema can happen in a breast cancer patient? After a few days of their surgery, or maybe it may extend up to 20 years after their surgical excision or after their radiation therapy. We will just have a brief outline about lymphedema. This is a chronic medical condition with an abnormal accumulation of protein-rich lymphatic fluid in the interstitial space. This causes physical, socio-psychosocial, and the occupational performance in the patient. Secondary lymphedema is considered to be the most frequently caused by surgery or maybe due to radiotherapy in the breast cancer patient. We discussed this in the last 2 days, a lot about the stages of lymphedema. So I want to tell only one thing: when physiotherapy is indicated, it's been indicated in stage 0, stage 1, and stage 2. Stage 3, which is very, very rare in breast cancer, and it is irreversible, as Professor Alphonse has told us today. So physiotherapy may not work in stage 3. What is cancer-associated secondary lymphedema? It's commonly called as breast cancer-related lymphedema. It is an edematous condition, which is specific and complex tissue biology. This has a clinical feature of increasing the limb girth. As I told before, the circumference of the arm will be increased with a fibrosis or inflammation and abnormal fat deposition. And there is a marked cutaneous pathology also. In the study which was done by Roxon, he gave a recommendation. And in the recommendation, he told that conservative complex decongestion therapy and the intermittent pneumatic pump has a high level of significance in the treatment. When coming to the surgical intervention, he recommends liposuction, but it is indicated only in the later stages where the conservative treatment fails. So when we see into the history about BCRL, when I was searching, the first documentation was in 1868, more than 100 years back. So I was wondering, Professor Juan Monseguil, he documented the development of manual lymphatic drainage as a treatment modality for the secondary lymphedema in breast cancer patients. Later in 1892, Alexander recoined the term and he made 4 pillars, which is very, very important for treatment of lymphedema. And they are lymphatic massage, inelastic bandaging, and care to the skin, and the last one is exercise. In the early 1930s, Emil refined the term as lymphatic massage into a therapeutic way of giving the stroking and its manipulation, and we are still now using these techniques. So we will move on to the oncology rehabilitation team. Nowadays, we are moving from the multidisciplinary team to the transdisciplinary team. We all know the multidisciplinary team in the oncology rehabilitation. This has been headed by the oncologist. He may be either a medical oncologist, surgical, or a radiation oncologist, followed by the rehab specialist and the physiotherapist, occupational therapist, psychologist, medical social worker, and rehab nurses. What is transdisciplinary? This combines inter and the multidisciplinary with a participatory approach. What is participatory approach here? We are going to take the active involvement of the patient and his family. So this is what we are going to involve in the transdisciplinary approach. So this is a family-centered process for supporting the family as well as the patient. So we are going to actively involve the patient as well as his family members in the rehabilitation. What will the problem list in the secondary lymphedema? Pain is the first and the common problem, and the patient will tell pain around shoulder and the chest wall and in the upper extremity. They also complaints of decreased range of movement in the shoulder and the joints in the upper extremity. Weakness of the upper chest muscle as well as the arm muscle is being documented. Patient also tell numbness in the upper part of the body, and they feel they are physically unfit and they are having depression and anxiety. They also have a decreased body part movement, that is in the other part, maybe in the trunk, they have a reduced movement. And they have the Webb syndrome and altered sensation like tingling, itching, or burning. Some of the patient has been documented with partial dislocation of the shoulder also. So after going through the problem list, we will go for the goals. What are the goals we have to frame in managing the lymphedema physical therapy? The first and the foremost thing is to increase the range of movement or flexibility of the joint. Second one is to decrease the swelling or edema. The third one is to decrease the pain. And we have to concentrate in strengthening the muscle also, because some of the muscle may get of the incision which was done during the surgery. The final one is to restore the function. That is, all the activity of daily living has to be restored. And overall, we have to improve the quality of the life of the patient. So we have different types of used. Professor Anwar has explained a few techniques. So we'll be rushing quick into that. The first and the foremost one is the complex decongestive therapy. So we will move into that. It has 4 main techniques. The first one is manual lymph drainage, which has a special stroking massage with the scoop or circular or maybe a kneading can be done around the limb. The second one is myolymphokinetic exercise. This is a specialized exercise whereby we are activating the muscle to compress the vessels which is deep into the muscle. The third one is compression bandage and the supportive garments. And the fourth one is the skin care. So here we are dividing this into 2 phases. Phase 1 is a reductive phase, which includes all the 4 maneuver. It is being given for 2 to 3 weeks. And in addition, you have to tell the patient to have the instruction that they have to have a compression garment, or maybe they should maintain the hygiene of the skin. In phase 2, this is the maintenance phase, which extends from about 3 weeks to 8 weeks. Here we will be including some exercise program and advise the patient to go for a self-massage also. Pneumatic compression or pressure therapy. This is a special device which is being used, and we have a pneumatic cuff. You can see here, this is a pneumatic cuff. It is like a boot for the lower extremity or like a sleeve for the upper extremity. So the compressed air is being given to the limb. So always remember the air or maybe the compression should be applied from distal to proximal. So this will help the drainage of the fluid more effectively. It's been documented that we can use low pressure pneumatic compression as well as high pressure pneumatic compression. What is low pressure? Something which is between 30 to 60 mmHg. Always considered to be more effective, and it is having a very less risk on the patient. But some studies also support high pressure, which is from 80 to 110 mmHg. The next one is the compression garments. So this is made out of a low stretch bandage or the elastic garment. So this is basically an elastic cloth or a resistant rubber. Again, the pressure should be evenly distributed all over the limb. Make sure that the distal part is having more pressure and the pressure is being reduced when it comes up. Take care that don't advise compression garment in patients who have sensory paralysis or nerve paralysis or peripheral arterial disease. Again, this is contraindicated strictly in acute inflammatory condition such as cellulitis, congestive heart failure, and acute venous thrombosis. Aqua therapy. This is doing exercise inside the water, managing lymphedema and combining the physical property of the water. Plus we are doing exercise, compression, and techniques which is involving lymphatic drainage. This uses the buoyancy, resistance, and the hydrostatic pressure of the water. So water level at the chest is going to reduce 90% of your body weight. So what will happen? The patient will feel extremely lighter extremity. So they feel the weight of the extremity is reduced. So this increases their confidence level and they can do exercise for a long time. In addition to this, when you are going to do a muscular contraction, this is going to put pulses on the neighboring blood vessel. That is, it is going to compress the neighboring blood vessel. Thereby it is going to move the diaphragm also. All this encourage the lymphatic circulation. Coming to the elevation of the arm. Yesterday, Professor Alfonso also mentioned about this. This is recommended to the patient to elevate the affected limb and sleep with the arm pillow or maybe an arm elevated foam. Again, this is advised only in the initial phase of lymphedema. This may not be very practical for a patient to always elevate the limb and do the function of the upper limb when he is awake. For example, elevate the arm and walking in the floor. It may be not possible for the patient. But again, if swelling is reduced, if a marked swelling or if you find swelling is being reduced, then give low stretched elastic garment for the patient, so it will be more helpful. About the exercise, this is the second most commonest tool which is being used by the physiotherapists nowadays. What are the effects of exercise on lymphedema? This will reduce the volume. It helps in increasing the muscle strength. It maintains the good level of mobility, that is your range of movement. It also helps in weight reduction, and overall it increases the quality of life. What are the type of exercise we can do? We can go for stretching exercise, aerobics like cycling, walking, swimming, and rehabilitate exercise with or without weights, that is with the dumbbells or maybe with TheraBands. We can go for some simple rehabilitation exercise of all the joints, active mobilization of all the joints. It's been documented that physical activity increases the lymph volume from 2 liters to 3 liters in 24 hours. So keep on moving your limbs. Better result has been documented when we do trunk clearance exercise along with the lying position and elevation for 30 minutes, and in between if you just move your fingers. So what the National Institute of Health and Care Excellence, NICE, is recommending, it's recommending that exercise can improve the quality of life in the breast cancer survivors. And they recommended these exercises like positioning, breathing exercise, and all joint exercise like neck exercise, shoulder, arm, and till the hand. What are the special consideration you have to do when you are going for an exercise therapy? Because you all know breast conservative surgery is of different types, and there may be a reconstruction surgery in which the muscle flap from the dorsal, from the latissimus dorsi is being transferred into the breast to give appearance or maybe for the cosmetic. So what you have to do, you have to concentrate on these muscle which is being incised or the muscle which is being cut. So we have to concentrate on this muscle to strengthen this muscle. So this we have to keep always in our mind. There are some additional machines what we are using like high voltage electrical stimulation. We all know electrical stimulation is going to contract the muscle and relax the muscle. So whenever there is a contraction and relaxation, there will be pumping of blood or maybe the lymphatic flow will get increased. So again, this is indicated in acute and chronic pain, mostly in acute and chronic pain patient.
Excuse me to interrupt you, Dr. Leo. Please finish within 2 minutes, please.
Yes, doctor, I will do it. What about the role of laser? Laser also is helping in the lymphogeogenesis, that is in the regeneration of the lymphatic vessels, as well as it also helps in the lymphatic movement and development of the macrophages. We will look into the evidence, what the evidence is telling. When we see the first one, it is telling that when we are going for a lymphatic drainage, it is going to give about 20% of reduction in the volume of the secondary lymphedema. Similarly, a study which was done in 2012 also supports that lymphatic drainage is going to reduce the lymphedema by about 25%. So again, a study in 2015 combined the lymphatic drainage with compression bandage, and they have documented about 7.11% or more than that. 50 to 70% of the reduction of the lymphedema volume is being documented by several studies, which is shown here. So most of the studies is going for compression decongestion therapy treatment, CDT. So again, the highest importance of exercise is being given. So the exercise is going to reduce the weakness as well as the pain. When we talk about the overall evidences, compression therapy, elevation of the affected leg, or maybe hydrotherapy, high voltage electrical stimulation, laser, manual therapy, kinesiotherapy, all these complementary therapies are giving only 5 to 11%, and this result is not significant. As I told before, compression decongestion therapy, CPT, is going to be used as a one of the common tool. So I took as a review of studies done over the 10 years period from 2006 to 2016, and it got recently published in 2018. So the result is supporting that there is a volume reduction in lymphedema as well as improvement in the quality of life. Thus, this study concludes that CDT is an effective treatment modality for the early stage BCRL. Coming to the conclusion, as I told before, CDT has a strongest scientific evidence. So in most of the cases, we recommend complex decongestion therapy rather than using a passive modalities. Combining it with other techniques such as pneumatic compression has higher efficiency. So we can always use the CDT along with pneumatic compression or compression garments. Again, coming to the passive therapies like high voltage electrical stimulation or laser therapy, it does not have any significant result, and yet the research is going on. Maximum benefit is evident when physiotherapy is started early. And this concludes that physiotherapy has an important role in integrated management plan of breast cancer patients. And these are the references which was missed in my slide. I take this opportunity to thank our overall chair, Dr. Grein, and the chairman of the scientific and the organizing committee, and all the vice deans of our college and my HOD, Dr. Omar. And this is the slide which is going to give importance today. Regular physical activity will help lower our cancer risk. I request all the listeners to do physical activities regularly so that we will escape from most of the diseases in this pandemic, because pandemic is making us inactive. So be active and stay fit. Thank you.
Thank you so much, Dr. Leo. We wish we could have more time to sit with you. It's a great talk. It's interesting. So I think now we may just get one question. Dr. Shahnawaz, if you have one question, because we'll go with you quickly, please.
Okay, doctor. Thank you very much, doctor. Dr. Leo, first of all, it's a great presentation. So you have summarized the role of physiotherapy in breast cancer and what are the physiotherapy options available for the lymphedema patients, and you have problem list of the lymphedema. So I have a question like, can you share your valuable inputs that we are having the protocol of lymphedema? So like, for an example, how many days we want to do the session for this lymphedema patients, or for what we should include in that components?
Yeah, actually, the American Cancer Society breast cancer rehabilitation guidelines stating that the patient has to do an active lymphedema management at least for 2 to 3 weeks, which was telling, and they have to do the maintenance of lymphedema exercises throughout their lifetime, just as a prophylactic or maybe as a preventive measure.
Okay, thank you. Thank you very much.
Thank you so much, Dr. Leo. It's a great and interesting topic. And now we'll go with the second excellent doctor is Dr. Shahnawaz Sayed. Dr. Shahnawaz Sayed, he working in organizing committee of this conference. He will work with us, so helpful. So he will talk today about nerve gliding technique on upper extremity function improvement in post-surgical breast cancer case report. And please welcome me to join Dr. Shahnawaz. You have 15 minutes, Dr. Shahnawaz, to done this presentation. Thank you so much. You can share your slide now.
Yeah. This will stop the screen sharing.
Yeah, sure, please.
You want to ask? Assalamu alaikum, doctor. Is my screen is visible, doctor?
Sure, yes, it's visible. Thanks.
Okay, thank you very much.
Thanks.
Thank you very much for giving me this opportunity to present my case report on the nerve gliding technique on upper extremity functional improvement in post-surgical breast cancer patients. Basically, it is a case report. We are not having much evidences or researches on the nerve gliding technique. So when we have observed, according to Lassie et al. In 2002, they have observed that breast cancer is the most common cancer among women in the world, and they are having the impaired shoulder function and well-known frequently seen in the early breast cancer patient. The problem list which we have observed in this post-surgical breast cancer patients, the problem in the limb edema, decrease in the shoulder mobility, and neural tissue injuries, which is causing a sensory and peripheral motor dysfunction, and also pain in the upper body of the limb, which are the most common post-treatment. According to the recent epidemiological study, according to Rentala in 2030, that aerobic physical activity, when we use it, it will diminish the risk of the breast cancer. It should be, that's why we need to do regular physical activity, at least 30 minutes per exercise. So the neurodynamic techniques which address it, so that will helpful in decrease the neural ability and heighten the sensitivity, which were progressed on the basis of the patient tolerance. The main objective of this case report is the study was done to evaluate the effect of the nerve gliding technique on upper extremity functional improvement in post-surgical breast cancer patient. Basically, this study is a case report, and it has approved from the local ethical committee. Signed informed consent was taken, obtained from the patient, and this is a case report. So we have tested the potential for the nerve gliding technique, and also we have added the specific home-based exercises for improving the range of motion, pain, and functional of the post-surgery breast cancer patients. So Mrs. Wanjere, a 60-year-old woman, she is a non-smoking woman, was evaluated in an outpatient physical therapy clinic. She was 62.5 inches tall and weighed 133 pounds, whereas his body mass index is 24. She was originally diagnosed with the left breast invasive ductal carcinoma. And when he woke up early in the morning, he used to complain 3 to 4 times pain per night. She reported a periodic cramping in his low thoracic region exertion. So when we asked her to rate the pain levels on 0 to 10 visual analog scale, which is a numeric pain rating scale, so she reported a moderately severe pain. So approximately 5 to 10, she used to complain in her neck region, and it is ranging more than moderately severe to 7 to 10, and in the shoulder region, and also in the low thoracic area. So the participant was given this nerve gliding technique, where the main physiology behind is the neural tissue longitudinal glide of the upper extremity. So this nerve gliding technique, basically it will be used as to assessment and also the treatment purpose. It is used for 10 minutes. Each session will be continued for 40 minutes, approximately 4 sessions we have done for a week, for a total duration is 12 weeks. So the participants, we have used this neurodynamic technique consisting of neural tissue longitudinal glide using the upper limb neurodynamic test. This tension test we have given for median nerve, ulnar nerve, and radial nerve, because all these nerves are supplying the muscles of the upper extremity. So this tension types test when we combine with the contralateral rotation and also lateral bend with the cervical spine. So the nerve glide has applied for 10 minutes. Each session will be continued for a 40 minutes of time, and 3 sessions has included in a week for 12 weeks. So the interventions after giving the nerve gliding, we have also included the home exercise program. So first we have given a proper education instruction to the patients in applying the heat and ice use the scar area and the pain area, and also a gentle home exercise mobilization, range of motion exercises, and stretching exercises. So the basic inclusion is we have included from the Department of Gynecology, so where the patient is having no contraindications and informed consent has taken. So the outcome measures which we have used in this case report was the range of motion, pain rating scales, strength test, and the shoulder pain disability index, which is an outcome measure, it's a SPADI. So this is we have used it for, this is the nerve gliding technique which you use it for the median now, and this was for the radial now, and this was the treatment technique of nerve gliding for the ulnar now. So this nerve tension test is having these components. When we are doing the median now, it includes shoulder abduction, shoulder girdle depression, and shoulder external rotation with forearm supination, wrist and finger extension and elbow extension, and cervical side flexions. For radial now, if you are performing it, it will be, it has done with the components like shoulder girdle depression, elbow extension, medial rotation of the whole arm, wrist and finger thumb flexions. Where the musculocutaneous now is for shoulder girdle depression, elbow extension, shoulder extension, ulnar deviation of wrist with thumb flexion, either medial and lateral rotation of arm, For ulnar now, it is shoulder girdle depression, shoulder abduction, shoulder external rotation, wrist finger extension, and elbow flexion and shoulder abduction. So when we observed the results, we found the most noticeable improvement in the mean age of 30.8 degrees after the nerve gliding techniques for 12 weeks. The shoulder abduction, which is mainly involved because of pectoralis major muscles, has been dissected as a surgical procedure. So we have got this movement has been improved with a 52.4 degrees, which was obtained after the treatment of the nerve gliding. And the SPADI score, so which is a outcome measures, it has included all the components of pain and functionals. So it shows a 13% of the improvement. And also we have followed a shoulder assessment by using a constant shoulder scores, which is composed of both subjective and objective parameters. So the manual muscle testing, if you observe, these are the improvements which we observed in the long flexor muscles by using the MMT. So where it is a normal, it has not involved. So when coming to the abduction, so before applying, it is around 4. So after that, we have improved in the normal. So you will get a grade 5 of MMT when we use it the manual muscle testing. So coming to the range of motions, so we got a range of motion, flexion range of motion improved from 20 to 30 degrees, and abduction also we got a variation in the differences. So this is the SPADI score. SPADI score has been reduced in the sense this outcome measure is when you are having the highest score means it is a worse condition, means the patient is a disabled. If you are getting a score of lowest means it is the best outcome. So in this case, we got a difference of 13% of improvement by using this nerve gliding technique. So nerve mobilization, which is improved the restricted nerve gliding and helpful in the reducing the scar and increasing the intraneural blood flow. So according to Page et al., so the combination of the manual therapy and strengthening, which is helpful in increase the function and range of motion of the adhesive capsulitis, so that we have used this technique on this breast cancer patients. So there is also evidence that peripheral nerve, when we create a tension or presence, it will glide an interfacing tissue, which is helpful in improving the functions. So the conclusion is we have used this case report for 12 weeks of physical therapy intervention along with the home exercise program. So where there is an increase in the, we found that it is increased in the range of motion, decreased pain, and improved functioning, and improved the SPADI, and which shows a significant improvement. But as I said, these results, this is only a case study of a female patient, so we can't be generalized for all the population. So it is the goal of this case study was to corroborate the past research and provide the recommendations for future research that could eventually generalize the effects of the nerve gliding techniques on post-surgical breast cancer patient. So we are recommending to perform it in a large sample size so that it will determine whether the nerve mobilization technique should prefer the post-operative procedures, and it should be done on a multi-center price. So we need to use more physical objective measures, like if you are using the MRI or SPECT scans, it will be more beneficial. And these are the references. Thank you.
Thank you so much, Dr. Shahnawaz. It's a great talk. You can put reference. Sorry, I just interrupt you for the last slide. Yeah, you can put reference because the people maybe they want to see your reference. Yeah.
Okay.
Yeah, keep going. So do you want to say anything? No. Okay. So I think it's a great talk from Dr. Shahnawaz, and interesting case study, to be honest. And I have to say that the scientific committee, it's outside from university, and they evaluate all papers coming to the conference. And paper from Dr. Shahnawaz got higher score on preliminary stage assessment of conference. So it's high work, output. So Dr. Liu, just go with if you have a comment or question so quickly, please. Dr. Liu is a chair for this session. Yes.
Yeah, thanks a lot, Dr. Shahnawaz, for sharing your views about nerve gliding technique. And it was an excellent and justified work for you, by you to your patient. And it has definitely added a value in the research to start working out more about nerve gliding technique in the post-breast cancer surgical patient. I have only one question. You told you have used ULTT. Have you used all 4 techniques of ULTT? And
yes.
Yes, for 10 minutes.
Yes, doctor.
Yeah. And have you adopted any grades of mobilization, or you have given in the general?
No, in a general way, doctor. We have not get, as a patient came, just we have applied the ULTT.
Okay, so
No,
10 minutes, 10 minutes each technique. So about 40
each
minutes.
Technique 10 minutes. Yes, duration.
Excellent, excellent. Thank you, doctor. Thanks a lot.
Thank you very much, doctor. And thank you very much to Dr. Thank you.
Thank you so much. As you said, Dr. Shahnawazi has 50 articles in physiotherapy science, and he is editorial board in 34 index medical journal, and we are so happy to work with him in the college. So now we'll go to the next speaker, and sorry we late for him, is Dr. Mani Al-Shehri. Dr. Mani Al-Shehri is he's a postgraduate fellowship Harvard Medical School Higher Impact Cancer Research Program. He's also associated research scientist at Cellular Therapy and a center and Cancer Research Department at King Abdullah International Medical Research Center, KERMAC, in Riyadh. He is also a visiting assistant professor at Prince Noor bin Abdurrahman University, Riyadh, Saudi Arabia. So he will be, just 1 second. Yes, he will be next speaker, and he will talk today about tumor heterogeneity in breast cancer. And please join me to welcome him and start his presentation. So, 1 second.
Hello, everyone. Thank you for attending this talk, and thank you for the organizers for giving me this chance to talk to you today. Today, I'll be talking about an important topic, which is cellular and molecular heterogeneity in breast cancer. I'm Mani Al-Shehri. I'm associate research scientist working at King Abdullah International Medical Research Center in Riyadh, and I'm working in the cellular therapy and cancer research department. So today we are going to talk about the heterogeneity of breast cancer. And as you know, breast cancer is one of the major cancer types in most of the women in the whole world. And what you can see from this map, which is indicating the breast cancer in pink here, the top incidence cancers in more than 100 or around 158 countries. And in 2020, there were around 2.3 million new cases diagnosed with breast cancers. Around 685,000 out of these 2.3 died, unfortunately, from the breast cancers. And for a long time, really, we thought that breast cancer is a single disease. And that was fine because all of the patients were treated by radical mastectomy, and that all patients were treated in a similar manner. But despite the fact that breast cancer was thought of as a single disease, pathologists actually took the exercise to actually grade the cancers and report the typing, grading, and reporting the tumor size, as well as the presence or the absence of lymphovascular invasion. Here is a typical example of invasive ductal carcinoma. This is a breast excision. And in the center of the specimen, you can see the breast cancer. It's a white gritty tumor, and there are some lines that's going out of the tumor invading to the normal tissue there. And as I told, as I mentioned, the pathologists have had the habit to report the type and the grade of these tumors. So grade 1 tumors, grade 1 tumors breast cancer are characterized by well-developed tubule formation, relatively little nuclear polymorphisms, and few mitosis. On the other hand, grade 2 cancers have lesser degree of tubule formation, slightly more nuclear polymorphisms, and slightly greater number of mitotic figures. Invasive carcinoma that are grade 3 tends to be solid in structure, have much greater degrees of nuclear polymorphisms, as you can see in the higher power here, and also more frequent mitotic figures. And interestingly, in that time, it was demonstrated that the histological grades actually correlated with the outcome of those patients. And what we can see is that the grade is correlated with the outcome of the patients based on their grade. And what we can see here is, for example, grade 1 have much better outcome compared to patients with grade 2 and 3. Moving to the identification of the estrogen receptor, and in that time point, we were able to divide breast cancer into two main different groups. The AR positive cancers, which represent a large majority of tumors, and the AR negative cancers, which were smaller minority cancers. And this correlates well with the clinical observations, and that there were some patients, regardless of the fact that all patients were treated in a similar manner, there were some patients who had better outcome, such as postmenopausal patients who tend to have tumors that behaved in more indolent manner, and patients who were younger tend to have a more aggressive tumors. And it was found that these younger patients, they were more likely to have estrogen negative cancers compared to the postmenopausal patients who were more likely to have ER positive cancers. And in this slide, what it shows actually, what we can see is that the patients with ER positive disease had a much better outcome compared to patients with ER negative disease. And then after that, the next milestone was the identification of the HER2 receptor. And this enabled us to further subclassify breast cancers, such as that ER positive cancers can be further subclassified to breast cancers, ER positive cancers that could have either positive or negative HER2. The same thing as with the group of the ER negative cancers that can be also subclassified into HER positive or HER2 negative cancers. And then at the beginning of this century, the introduction of gene expression profiling studies, and it was a big movement to classifying the whole oncology field actually, and here in breast cancer. And these really brought a new way of thinking about breast cancers and the identification of several new subtypes, or at least different ways of thinking about classifying breast cancers. And what we can see from this diagram here, that we are still having two main subtypes. And these branches represent the ER positive class or the ER negative class of tumors. But within the ER positive group, we have several subtypes known as laminal A or laminal B, those are two being the main two subtypes. And within the ER negative groups, there were the HER2 enriched group and basal-like subtypes. There were also a group identified known as normal breast-like. which is not clear whether this represents a true tumor subtype or whether it's just a contamination by normal tissue. Now, the interesting thing about the molecular classification, not only has it given us a new way of thinking about breast cancer, but it also has a prognostic significance. And I think that is why it has gained so much attention, actually. So what we can see here from these different data sets, that the luminal A cancers have the best outcome in all different studies. And the HER2 and basal-like in red and pink have the poorest outcome. These outcome curves predict the use of Herceptin and the luminal B cancers, the Herceptin. Here we can see also the luminal B cancers are somehow somewhat in the middle. Now, following the introduction of this methodology, there were a large amount of publications looking at different gene expression signatures as a way of predicting the survival of patients with breast cancers. And in this paper from the New England Journal of Medicine is an example of that, in which the investigator examined 295 patients with stage 1 and 2 breast cancers, and they evaluated their expression signature, which consisted of 70 genes. And these authors were able to stratify patients into good and poor prognostic groups. Furthermore, the expression signature were better than standard prognostic system based on clinical and histological features. And what we can see from these curves, from the figures in their paper, some of the patients, or there are metastasis free and offer, what we can see here is the metastasis free and overall survival curves. And what we can see is that using a Maury-Brent assay, which can stratify patients into a good and poor prognosis group. And the importance of this actually is that we could potentially save some patients from the need to have very strong cytotoxic chemotherapy if they have if they are shown to have good outcome in this prognostic group. As I mentioned, there were a large amount of studies looking at gene expression profile to stratify patients into these good and poor prognostic groups. And this group of investigators felt it's important to conduct a meta-analysis of these different studies to see how much they are overlapping with each other. And because many of the assays used in different studies, they use different number of genes. There seems to be very little overlap in the genes looked in these different signatures. So what's the meta-analysis found here? That the proliferation genes were the most common or the common driving force in all of these different reported prognostic signatures. Interestingly though, factors associated with tumor burden, like the tumor size, for example, remained independently associated with prognosis. To summarize this portion of the presentations, now we have the laminal A-like cancers, which are the hormone receptor positive, HER2 negative cancers that have a low proliferation rate, the laminal B-like cancers, which are hormone receptor positive, either HER2 positive or HER2 negative with a high proliferation rate. The HER2 enriched cancer, which are HER2 positive and hormone receptor negative, and the basal-like cancers, which are AR/PR and HER2 negative or triple negative. And the laminal cancer represents here around 70% of patients with breast cancers. HER2 enriched are seen in around 15%, and basal-like in a similar manner represent about 15% of the patients. So let's look at each of these different subtypes now. So the basal-like cancers, as I mentioned, are a subtype of invasive breast cancers that were first identified through gene expression profiling studies. And this group was so named because they express genes characteristic of basal epithelial cells. And as I mentioned, the group consists about or represents about 15% of invasive breast cancers. When we look at the histology of these cancers, we can see that they're uniformly high grade. They have solid architecture with no tubule formation and high density of epithelial cells with also having bushing rather than infiltrative margins. They also often have a prominent stromal lymphocyte infiltrations, and they have a high rate of mitotic rate. And this is an example. This is an example, a typical example of triple negative or basal-like cancers. You can see the feature that I just described. There is bushing margins. A tumor consists of a solid sheet of tumor cells with no tubule formation. There are a zone of necrosis, and you can see it here in the high also power. And also there are mitotic, high degree of mitotic figures. Another interesting concept actually, or a feature of basal-like carcinoma is that the majority of BRCA1 or BRCA-associated cancer are found to cluster with the basal-like group. And this would be really important later in the talk when I'm going to talk about target therapy for patients with breast cancers. Moving now to HER2 enriched breast cancer group. This represents, as I mentioned, around 15% of breast cancers. They are typically ER negative, and they are more likely to be a higher grade and lymph node positive. As far as their gene expression profile goes, they have a high expression of HER2 and other genes in the umbilical, and low expression of AR and associated genes. Patients respond to Herceptin therapy, and they also respond well to anthracycline-based chemotherapy. And they generally have a poor prognosis without those therapy being given to the patients. Moving now to look at the laminal B breast cancers. They represent around 10% of breast cancers. They are ER positive, but they tend to be higher grade and or have a higher proliferation index as measured by the proliferative marker Ki67. These tumors may overexpress HER2, in which case they are typically referred to be as laminal B HER2 positive. They do show high expression of hormone receptor and associated genes, and as I mentioned, high expression of proliferation-related genes. These patients often need chemotherapy in addition to their endocrine therapy, and the prognosis is not as good as it is for the laminal A breast cancers. Typical laminal B cancers then would be somewhat either grade 2 or grade 3. Here we can see that on H&E, There is poor tubule formation, some nuclear polymorphisms, and just few mitosis. The tumors is ER positive, PR negative, and HER2 negative. Moving to laminal A, like cancers, they are the most straightforward. They represent around 60% of breast cancers, and they are PR positive and low grade, and they have low proliferation index, and they don't overexpress HER2. And you might expect the gene expression profiling study show a high expression of hormone receptor and associated genes. These patients respond very well to the endocrine therapy, and generally speaking, chemotherapy is not indicated. Now, moving to the question, is there any heterogeneity within the molecular subtypes? And the answer is yes, even the subtypes have subtypes. And what we can see in this figure, the authors correlated the clinical pathological subtypes, that is in the immunophenotype, with the molecular subtypes. And we see is among the basal-like cancers, about 80% of basal-like cancers are triple negative. That is ER hormone receptor negative and HER2 negative. But between 5 to 10% may fall into these other categories of being either ER negative, HER2 positive, ER positive, or HER2 negative, or even hormone receptor positive and HER2 positive. The tumors that are the most heterogeneous with regard to immunophenotype relating with molecular subtypes are probably the HER2-enriched group, in which we see that only about 50% are hormone receptor negative, HER2 positive with between 15 and 20 falling into the other immunophenotypic subtypes. Laminal A cancers have the greatest fidelity between the molecular subtypes and the immunophenotypic, with almost 90% being hormone receptor positive, HER2 negative, and just between 2 and 5 falling into the other subtypes. And laminal B being somewhat in the middle, with about 70% of cancers being hormone receptor positive, HER2 negative. A fair number, maybe around 20% being hormone receptor positive, HER2 positive, and the remaining falling into the other categories. So now getting to the aspects of molecular heterogeneity, which was one of the charges of this presentation. We can look at the work from the Cancer Genome Atlas project, in which these investigators conducted many different types of molecular analysis to evaluate breast cancers. What the investigator found was the breast cancer could be classified into those same 4 molecular subtypes that I have been speaking about: the laminal A, laminal B, HER2-enriched, and basal-like subtypes. And then in rows are different breast cancers, and in columns are different mutations that they were identified. And what you can see with regard to molecular heterogeneity is that even though I said laminal A cancers were really perhaps the least heterogeneous, you see that even among this population, only about 2/3 show the PIK3CA mutations, with several other mutations also being found, but not being found in every single cancers. And on the other hand, among basal-like cancers, we see that P53 mutations tend to be very common, but again, not uniformly seen in all patients. So we can look here at the proportion of patients in laminal A group. About 45% will have the PIK3CA mutations. Among the basal cancers, about 80% of them will have P53 mutations. But again, not all of the patients having these mutations. And interestingly, despite all of the mutations looked at, only 3 genes were found to be mutated in greater than 10% of the tumors. That being P53 in about 2/3, PIK3CA again in about 2/3, and GATA3, which is an estrogen-related gene seen in about 10% of breast cancers. And I have been discussing the molecular subtypes, and the reason that we have a greatest deal of interest in them is, firstly, that give us another way of thinking about breast cancer and classifying breast cancers. I have already mentioned that these subtypes have prognostic value, but also very therapeutic implications and correlate with the outcome. And what I mean by that is the gene expression analysis can be used to reveal novel therapeutic opportunities for patients with breast cancer, because we can use expression profiling to relate different molecular subtypes to pathway dysregulations. And what has been shown is that some pathways are highly correlated with subtypes, and other pathways show variable activity within the subtypes. And we can see this from this heat map from this paper that I'm discussing. And so among basal-like cancers, we see that a large majority of them have the P53 mutation, as was similar shown in the Cancer Genome Atlas network publication that I showed earlier. And also, a vast majority of them have mutations in HER1 or EGFR receptor. And on the other hand, among the laminal A cancers, very few of them have mutations in these genes. So if you were to think about therapeutic targets, for example, you might think about a target to P53 for patients with basal-like cancers, but you will not be, or you don't want to use that in patients with laminal A cancers. And then if you look at PI3 kinase, we can see that patients with laminal B type cancers, it's very heterogeneous, and with regard to the identification of the mutation in this gene. And one will not expend or there are several commercially available signatures at this point in time. MammaPrint is very widely used in Europe, but also used in the US and in some part of the world. Oncotype DX is perhaps the most widely used in some labs, but there are also other assays such as genomic trait and intrinsic subtypes, or PAM50, which is gaining some of the market share. Patients for whom these tests are indicated are those patients that have ER positive cancers, that is the laminal type cancer, because patients with ER negative cancers we know have a poor prognosis without the use of chemotherapy. So the reason to use these tests are to help clinicians decide which chemotherapy is appropriate, and patients with ER negative cancers would need chemotherapy regardless. So here is the Oncotype DX assay, which is RT-PCR-based assay that consists of 21 genes. As you can hear, there are different genes for proliferations, and there are five reference genes that are used in this assay for validations. And the Oncotype DX is a multi-gene assay to predict the recurrence of tamoxifen-treated node-negative breast cancers. This assay was tested on 668 ER-positive node-negative patients enrolled in a prospective clinical trial. This assay is, as I told, RT-PCR-based assay that can be performed on paraffin sections, and they use 21 genes. And these are the genes involved. As I told in the beginning, they are different genes that they can predict the proliferations. Now, this assay has also been shown to be beneficial regarding the prognosis, and has also been validated in 2 independent clinical trials, and both have shown very low rate of recurrence among patients with low recurrence scores. So the assay can score the recurrence based on some scales, and it's scaled them to low, intermediate, and high. And you can see the results of this assay can predict the patients with low risk, intermediate risk, or high risk with the recurrence. So what about the heterogeneity and its role in the recurrence setting? So we learned that the tumor, the breast cancers has different subtypes from patient to another. This is called intertumor heterogeneity. And also in some cases, the breast cancer will metastasize to different organs, to brain, liver, lung, or to the bones. And these represent different clones, which is, they are heterogeneous, they are very different, and they are heterogeneous. But what is happening sometimes in the clinical practice, that breast cancer will be, the biopsy from a breast cancer will be taken, and the treatment will be planned based on that biopsy. And this is sometimes leading to a recurrence of the tumor. And you can imagine that using a treatment which is specific for the subtypes or the cells, the clones that was isolated in the biopsy, the treatment will eradicate that clones, but it will give a chance for other clones in the tumor microenvironment to grow and to be responsible for the relapse. And the relapse can be either by a different strategy. One of them is the presence or the existence of a clone, which is having the resistance for the treatment that's being used for the patients, but it was not very represented in the first place. So with targeting other clones, this clone right now will have the chance to overgrow and repopulate and responsible for the relapse. The second scenario is that the birth of another or a new clone that induced by therapy-induced clonal evolution. And this would be one clone will be acquiring more mutations. That, for example, if it's the treatment against that clone, it will acquire some mutations that right now will not be respond to the same treatment. As you can see here, the emergence of this purple clone here to overgo and be responsible about the relapse. So what we are right now in the lab and what the field is moving towards genomic analysis. And they're trying to use the molecular subtypes for the patient towards personalized medicine. And this is by identifying some mutations, copy number changes, or translocations. And this is using different techniques, including whole genome sequencing, whole exome sequencing, and so on. And the goal of all of these techniques actually is to identify actionable targets in order to personalize the therapy, meaning we have mutations that we can target that with a certain treatments. But there is a caveat for this, because those techniques or sequencing techniques usually give lots of variants. Sometimes in the clinic we call it variants with unknown significance. So we don't know, is this actionable or not actionable? Is it useful clinically or not? And sometimes it's only adding more complication to the topic. So again, there are also in the differences between patient to patients, and even in the patient himself, there are different clones that are heterogeneous from each other. So right now the field is moving to identify the heterogeneity using different methods. There are right now advances to use liquid biopsies to identify the heterogeneity, and this is by using either small extracellular vesicles called exosomes, or by the circulating tumor DNA, circulating tumor RNA, or even non-coding RNA, or the circulating tumor cells. And this can be representing the heterogeneity maybe more compared just to using a tissue biopsy. So what we are trying to establish right now in our center and in other centers is the personalized medicine method, where we usually take a biopsy, we send it for sequencing to identify any actionable mutations. And this is if we find one, the patients will be getting the treatment right away. But at the same time, we are isolating patient-derived cells, and we are making models. This is, in this case, tumor organoids that we expand in the lab, and we use different treatments that can be used in the clinic to predict the response that will happen for this treatment. And based on this, we can guide the clinical management. Again, we can also use this model in xenografts. In this case, we call it patient-derived xenografts, by engrafting the patient cells to the animals. Then after that, because they mimic the microenvironment in the patients, not totally, but at least to some degree, we use the treatments then in those conditions to see if we can come up with a single treatment or a combination of different treatments that can be given to the patient later on. So in conclusion, AR, BR, and HER2 status are the major drivers of clinical decision making regarding the type of systemic therapy. There are lots of expression analysis assays that used in the clinic in patients with AR positive oncotype DX breast cancer. They can predict the need of the chemotherapy in addition to hormonal therapy. Tumor heterogeneity in general tumor heterogeneity is a key player drug resistance. More new methods are right now being used to identify tumor heterogeneity. And if we understand the tumor heterogeneities, this is the way towards the personalized medicine. Thank you so much, and I'm happy to answer any questions.
Thank you so much, Dr. Mane. It was a great talk today. So we are, it's so exciting, interesting, and it's really depth information and knowledge on this presentation. So my question to you, Dr. Mane, what will be the best practice, what will be the best procedure to treat the patient with knowing the heterogeneity of breast cancer?
Well, I thank you so much for the nice question. So I think this is the golden questions that we would like to answer, all of us. You know, there are lots of heterogeneity. I think trying to treat a patient right now would be a complementary work between identifying the heterogeneous population that patient has, and then after that we can decide and come up with a treatment plan, sometimes with even a combination of different treatments that can be given to the patients to overcome some of the heterogeneity that we can see and the possibility of the relapse.
Thank you so much. Dr. Abdelmonem, I think you have a question. Go ahead, Prof. Abdelmonem. You raise your hand. Prof. Abdelmonem. So what's the modality for treatment we can use for heterogeneity breast cancer? What's the modality of treatment we should concentrate on the clinic? I mean,
yeah, so I will be showing some examples in the next presentation when I'm talking about the metastasis. Sometimes we see different clones, for example, HER2 negative cancers that in the primary. But when the patient comes with a metastasis, sometimes it comes with a different subtypes. And I will be showing a case where they are having metastasis of HER2 positive. So I think by applying different applications, so we can for sure do molecular subtyping and see if we can identify actionable mutations that we can use some treatment towards those actionable mutations. And then after that, we can also use all of the available markers that we can come up with the right treatment. So I think we are moving towards personalized medicine instead of just treating the patients all the same manner. So would be, I guess, in the future, the clinical practice would be specific for every single patient, not would be general as we used to do in the clinics.
Yes, in your presentation, you mentioned cRNA and cRDNA. What are the differences between them in kind of, if you talk about tumor heterogeneity in breast cancer?
Well, so the circulating tumor DNA and circulating tumor RNA, so these are small fragments that are released from the tumor cells. So the tumor cells, they undergo some stress sometimes, and they will be ruptured, and they will release those markers. And in the clinic right now, the circulating tumor DNA, they are used as a sign for the heterogeneity. Sometimes we are not able to pick up those mutations because you can come up with a mutation in those fragmented DNA. PI3K mutation right now, for example, in breast cancer is used as predictive, and even you can use to predict the response of the treatment. So if you have that marker as circulating tumor DNA before the treatment, but after the treatment you see it disappear sometimes it's telling you that there is a response and there is no more release of that circulating tumor DNA, because sometimes the current technique that we are using, if there is only few growing cancer cells, sometimes we are not able to detect them. But using those sensitive techniques right now, it's shedding light more to the response, the heterogeneity, and the other aspects.
Yes. Is there any related information related to the, like at the beginning of breast cancer or the advance or progression?
Yes. So
it will change any result with us?
Yeah, so the amount of these markers, usually the circulating tumor DNA or RNA, it's usually the tumor burden. So if you have huge number of cells, huge number of tumor cells that are over there in the breast, for example, they most likely have huge number of circulating tumor DNA. And this is also would depend on the hypoxic condition. When the cells, they are getting stress, they can't survive, they will be dying either by apoptosis or any other form of cell death. Then after that, they start to release those markers. So it depends on the size of the tumor. Also, is it having some, because we usually identify those in the circulation, is the degree of angiogenesis, which is the amount of blood vessels that's feeding the tumor, is high or low. That is another contributor factor of the enrichment of those circulating tumor DNA or RNA in the circulation. So there are different factors that can play a role in the enrichment of those markers that that can give us some indication on the progression of the disease.
Thank you so much, Dr. Mani. We are so glad to be with us today, and we are so excited to listen to the second session from you. Thank you so much. Thank you so much. Now we'll go with the second speaker, which is Associate Prof. Najat Zain Al-Toom. She will be next. It's our next speaker. She's she working in clinical nutrition department in College of Applied Medical Science. She has a long experience, and she is a consultant dietitian. So she will give us like a talk about 15 minutes about the topic patient education in breast cancer, which is the most interesting topic for, especially from the nutrition perspective. In this conference, we take the whole circle of breast cancer from beginning until the end. We don't concentrate to one area, like for example, oncology or diagnostic. We take all factors which is essentially affect the circle of breast cancer. So one of these circles will be the clinical nutrition perspective area. So thank you so much, Dr. Najat, to be with us, and the mic for you. And 15 minutes. Thank you so much.
Thank you, Dr. Grain. Good afternoon, everyone. Thank you for the invitation. I'm glad to be part of this event. I will just share my screen. The topic is about the patient's education in breast cancer. But during my search, I found that all patients with different kinds of diseases, they face problems nowadays because of the constraints of COVID-19 pandemic. We know that patient education is usually done as part of the clinical treatment, as part of the nutrition, as part of the management of the patients. But nowadays, many people or many professionals and patients, they face lots of problems to get the information, not in specific places, but all over the world. First of all, I would like to give a brief idea about the patient education. Patient education is known as a planned, systematic, and sequential process of teaching and learning. It provides, or it is provided to patients and clients in all clinical settings. So it is mainly delivered in clinical settings in hospitals and health institutions. And it is a continuous process, which means that there is a relationship between the patients and the healthcare provider. It involves the healthcare provider and the patient, and also sometimes the caregiver. The main goals of the patient education is to tailor individualized interventions according to the needs and the requirements of the patients based on the assessment, evaluation, diagnosis, and prognosis. But there is another concept that, or a sector of education related to health that is confusing people, and people might mix it with the patient education, which is the health education. Health education is more general. It is a teaching and learning process also, but it concentrates mostly on wellness, prevention, and health promotion, and provided to individuals, groups, and communities. The main goal of health education is to change and improve societal health behaviors. It's very important to differentiate between these two modalities of patient and health or patient education. Now, the patient education during COVID-19 has been affected like all walks of health services. We know that patient education is effective when it is given to patients, and patients receive information from the healthcare providers and then supplemented with educational materials that will help the patient to recall and take actions on what was communicated to them. Traditionally, it is one-to-one teaching with healthcare providers. In some instances, it is provided for a group of patients. But there are some factors that can hinder or slow down the process, especially during the time of what we are facing now during the pandemic of COVID-19. But in general, there are some factors behind these or behind the slow advancement in the patient education. First of all, translating evidence to action gaps at the health system levels. There is a gap. There are lots of researches and studies, but there is no enough translation of these studies in order to have evidence-based guidelines. Weak patient education skills and competences from the side of the educators in terms of adoption and implementation of the right competences, absence or slow development in health professional training programs. And this is something that I faced in the past few days when I was looking for an information about the number of health educators or patient educators in the Middle East or in Saudi Arabia. I didn't find anything. I made a personal contact with someone at the Saudi Commission for Health Specialties asking for the numbers. They said that recently some of the colleges, applied medical sciences colleges, started programs of health education. I'm not sure if there is also specified programs for patient education. Professionals who have certificates or courses or training programs are not classified as patient educators. So while we see lots of patient educators practicing in the hospitals and the different clinical settings, most of them, or you can say all of them, I don't have specific numbers, but from my experience in working in hospitals, and also teaching in one of those courses, diabetes educator course. These programs or these courses graduate lots of candidates, but they are not classified as patient educators from the Saudi Commission for Health Specialties, because this is not an undergraduate program or postgraduate program designed by specific universities or colleges. It is mainly provided by hospitals and tertiary care centers. So this might slow down the development of the patient education in some parts of the world. The other thing is that there is competition or competing priorities in clinics, mainly due to the time constraints. We know that education needs lots of time, and the healthcare provider needs to spend a considerable amount of time with the patient, especially in the initial visits. The healthcare providers' awareness about the importance of patient education is one of the lack of awareness or deficiency in the awareness is one of the factors. Access to quality patient education materials. And nowadays people are facing this problem because most of the educational materials are designed to be given to the patients, like pamphlets or brochures or booklets, some online information developed by some institutions and hospitals, but we do not have proper educational materials that can be that suit the digital environment and designed for patients with specific types of diseases. There is also another factor, which is the challenges with traditional models for patient education, which we can say old school methods of patient education. Still, we need to empower the patient educators with the modern models of patient education. There are barriers also from the side of the patient. Patients who is unwell or overwhelmed with the taking care of himself or dealing with the disease or other life activities will not be able to absorb lots of informations in a specific period of time and use and apply these informations. Patients, we know that patients, especially at the beginning, when they learn that they have, for example, like breast cancer or chronic disease, they experience fear and distress, and this also will create a barrier for motivational learning or the readiness for learning. The other important point is the low health literacy. Many patients around the world, they have low health information, and this also can create a barrier in receiving information. Looking at the data of using internet and social media in Saudi Arabia, because this is what is used to seek information nowadays in most of parts of the world. So I tried to look for information. I found these interesting data. It shows that people in Saudi Arabia spend around 3 hours, 2 minutes per day on social media. And the number of people who have active internet access, or they are internet users, are 93%. 0.3 of the population. And this is good because they have access to the technology, they have access to the information. Here we can see that social networks, platforms that mostly used by Saudis. We have YouTube used by 76%, and then we have Instagram by 65%. Pinterest and LinkedIn are maybe, especially LinkedIn is used by specific people, a specific group of people, professionals mainly. And then we have the popular messenger apps. WhatsApp is the first one, number one, 71%, used by 26.25 million. And then we have Snapchat, followed by Facebook Messenger, and the last one is WeChat. All of these platforms are used to seek information. And also it is used by different bodies and institutions to deliver information to their staff or to their clients. And nowadays we see that the internet is used and mobile phones are used to deliver information to the public. During COVID-19, the telehealth or telemedicine is started to be used more. There is a growth in using the telemedicine. Telehealth mobile applications used during COVID-19 in Saudi Arabia includes applications like Saha and Maw'id by Ministry of Health. We have Tatamman, we have Tabaud and Tawakkalna. And Saha and Maw'id are responsible for communicating with the patients by Ministry of Health, by the hospitals, in addition to other communication methods used by specific sectors, hospitals under specific sectors and private hospitals. This created an access to the healthcare services, including the patient education. And the National Health Information Center created also regulations for telemedicine. And these regulations was updated in 2018, and it helps people to regulate the practice of telemedicine or telehealth. Now, the burden of COVID-19 on the health services, including patients with breast cancer who needs to receive information and education, is reflected in one of the studies or a survey conducted by the American Society of Clinical Oncology to assess the public views on care and cancer care and research. The general population in this survey were about a little bit more than 4,000. 1,142 of the participants have cancer or had cancer. They are in remission. All of them are above the age of 18. And the survey was conducted between July and September. And the results were published by the end of September. On the right side, you can see that breast cancer patients represent 24% of the sample. And from the general sample, 13% have, of all types of cancers, 13% have active cancer, 73% had complete remission. So even patients with complete remission, they participated in the survey, and they answered questions related to the effect of COVID-19 on their health or clinical service, the clinical services provided to them. 64% reported cancellation or delay in scheduled tests including mammogram, colonoscopy, scan check, and PAP HPV. 63% were concerned about being behind on their cancer screening. So these are people who are not diagnosed. But when you look at the patients with cancer, 58% with active cancer experienced disruptions in their daily lives, including the delay in the appointments and other and tests and follow-ups. The other thing is that the delay in their the disruptions in their lives because of the concerns over the risk of contracting the coronavirus. Two studies, one of them conducted in the United States, one in the UK, showed that delayed diagnosis due to the pandemic are projected to lead to more cancer deaths over the next 5 to 10 years. So this is something serious. Patient education moved forward into the 21st century during COVID-19 pandemic, and it was forced to move forward due to the, and this led to rapid deployment of virtual care provided, which provided a unique opportunity to advance the delivery of digital cancer patient education. The question is, are we ready to do that? Do we have the skilled, competent manpower to do that? Do we have the technology to do that? And are the clients or patients ready to use such method of communication? Studies are going on all over the world, but as I said, the field of patient education is a little bit behind. The impact of COVID-19 on the cancer education and control, as I said, shown on different levels, cancellation of appointments, interruption, delay, or transition to virtual formats. And the transition to virtual formats for cancer education, for training, for and mentoring, and also mentoring activities at all levels. These also virtual formats used for cancer treatments, care delivery to patients with active cancer. Also delays and adjustments in recipient of guideline recommended prevention screening and early detection modalities among populations who are in need for this kind of service. This slide here shows the implications of health and digital care solutions during COVID-19. And it shows mainly the determinants that influence adoption of digital care solutions during COVID-19. As you can see here at the top of this graph, that there are many determinants, actually 3 of them. We have 3 groups. We have infrastructure, we have institutional, and we have human. But I think that the most important factor is the patient information needs. We know that during in breast cancer patients, there are lots of information to be delivered, from the diagnosis to the treatment to information needed by patient or cancer survivors, and any procedure that the patient is going to have during the process of the treatment, and information about life and what's going to happen in the future. The 3 determinant factors, major or main determinant factors or influences, are infrastructure, institutional, and human. And you can see that in infrastructure, complexity of IT technologies is one of the factors that will decide if you will have a proper telemedicine or telehealth services. Poor internet connection or broadband, mentioned by many people in this study and our review. And also this faces different people in different activities, including education, For example, around the world, people are using these settings or online education settings to deliver education to the students. So poor internet connection is one of the challenges of influencers. Data privacy and protection, and this is a huge concern by the designers of these infrastructures or the people responsible for these infrastructures. Institutional part includes technical support, number of staff, training, availability of funds to construct such system, compliance requirement, health licensing, and availability of health reimbursement. And the other thing is that the human factor, user readiness and ethical consideration. User readiness from both sides, patient and caregiver. Do they know how to use these technologies? Do they have the competence to deliver messages through these technologies or these platforms or digital environment? And what about the ethical considerations and patient privacy? So all of these are challenges that needs to be tackled nowadays in order to avoid any delay in patient education and other health virtual health services provided to the patients in future crises or emergencies.
Dr. Najat, thank you so much. Just within 2 minutes, please.
Yes, I'm just finishing. This is my last slide.
Yes.
Wozek and his group says that the society is diving into digital sphere in the middle of pandemic. As such, digital care has come to stay. So the digital care will stay with us for good. We need to know how to use it, how to utilize it. We need to prepare healthcare providers, including patient educators and patients and clients for this era of digital environment. And thank you.
Thank you so much, Dr. Najat. It's great explanation and presentation today, especially when you give information about which platform we should go, which we should decide. And I think you highlight a couple of points where we should go, what's the media we should take, what's the message we should deliver to the people. And because some messages nowadays we have a lot of messages we receive it in our mobile each day. So, but which message is attractive to the audience, to the people? So I think you highlight more information about health education to the patient, the way and the method to deliver the message. So please, if anyone has a question, please.
Thank you, Dr. Breen.
Yes. Yes, go ahead. Thank you. Is there any question? So, Prof. Abdul Manan, please.
Assalamu alaikum wa rahmatullah.
Alaikum salam.
Thank you very much, Dr. Najat. I have 3 comments. Just it's a matter of statistics and data. In the US, they have some statistics say that people high school dropout live less 5 years compared to graduate population. Do you think that this mainly due to lifestyle or related to nutritional factors or other factors?
This is something. Thank you for the question, Doctor. This is something that is multifactorial. Number one is the level of knowledge and level of education. People who are educated, whenever the level of education is higher, they tend to practice more in a healthy way. Lifestyle will be better compared to people with lower level of education. The other thing is that, especially in the United States, if you are not well educated, most likely the job that you will get will not pay you enough. So low income also contributes to that. Low income means less access to services, including health services. So people with specific types of diseases like chronic diseases might suffer to get the right healthcare services because they don't have insurance and they don't have income. So there are lots of factors, as I said, socioeconomic factors, level of education, and maybe the geographical area where they live also, or if they live in urban areas or rural areas, access to the service or healthcare services. So I think these are the main reasons.
Just to comment more, I think some factors are dependent of level of education, like smoking, for example.
Yeah.
Educated and non-educated are smoking at the same time. And also it is one factor, educated people and non-educated people. Is it cultural issues or?
I don't think it's related mainly to the culture, because in different cultures, I think it's more related to the willingness of the person to pursue education, and the surrounding factors, environmental, economic, and social factors. But cultural wise, you can see that, for example, here in the Middle East, we have the same, most of the countries share the same culture, but still the level of education is different between the countries.
Okay, the last question. The last question.
Yes, the last question. If we compared our societies here in the Middle East compared to Western countries, they take care very about junk food for children. As they convince families and they have program at schools for that. But I don't see anything here, such effort like that. But the opposite, they attract children for junk food by toys or by different things.
Actually, there are programs, as far as I know, here in Saudi Arabia and also in other countries, there are programs, including school nutrition programs in the communities, directed mainly to the children to improve their knowledge about health. And one of the goals of 2030 vision is to have more healthy communities, and that's why Ministry of Health and other bodies developed lots of programs, and they applied it actually. And even in the curriculums at schools, when I look at my kids' books, there are lots of information about health and nutrition and healthy eating and integration in the different types of courses and subjects. And even the awareness of children is increasing nowadays. They ask about the expiry date. Yesterday, my son was asking me if diet soda is healthy or not, and he is only 8 years old. So there is an awareness increasing. And nowadays, in the era of internet and social media, children are watching lots of advertisements. It's not only just in the restaurants, and they can be affected by that. So programs are initiated and working, and there are some results actually.
Thank you so much, Dr. Najat. It's a great talk today. Thank you so much. Thanks, Professor Man'em. Yes. Now we will go to the second speaker, which is Associated Professor Amir Saeed. He will talk today about the cause of breast cancer. Associate Professor Dr. Amir is working in Department of Clinical Laboratory, College of Applied Medical Sciences, University of Haifa. Thank you so much, and go ahead, Dr. Amir, please, no exceed than 15 minutes because we have the last session before the presentation for podium today. Thank you so much.
Thank you very much, Dr. Green, for giving us the opportunity to this wonderful conference. Today, I'm going to talk about resource use and cost associated with different stage breast cancer. Breast cancer, as we all agreed, is the most common female cancer, and this is the case also in Sweden. Breast cancer is a costly disease for the healthcare system, and from a social perspective, production losses due to the disease represent a substantial economic cost. Comprehensive studies on the resource use and cost associated with breast cancer patients in normal clinical practice are few. Therefore, the aim of this study was to investigate the resources, use, and cost associated with breast cancer in different states of breast cancer disease in normal clinic practice. A distinction is made between direct medical cost, direct non-medical cost, and indirect cost. Around total of 361 patients were included in a cross-sectional study. Patients were recruited as they attend a breast cancer outpatient clinic. Female patients with a previous diagnosis of breast cancer were eligible for inclusion. Patients who fulfilled the inclusion criteria were enrolled, provided that they agreed to participate in the study. The period of recruitment was during April and May 2005 at breast cancer outpatient clinic at Karolinska University Hospital, Stockholm, Sweden. A self-administered questionnaire was distributed to the study sample by a research nurse while patients were waiting to see the doctor or nurse. The questionnaire collected data on demographic variables in formal care provided by family and friends and work capacity. The defined breast cancer stage were divided to first year after primary breast cancer, state P, first year after recurrence, state R, second and following years after primary breast cancer or recurrence, state S, metastatic disease, state M. Medical resource use and cost were collected respectively for each patient included in the study from electronic record available through the hospital. Outpatient drugs, reliable data on the type and quantity of drugs used in the outpatient setting by the study sample was not available through the retrospective analysis of the electronic record gathered through Karolinska Hospital. We instead used expert opinion to estimate the type and quantity of outpatient drugs used in the various disease states. Unit costs were derived from the Swedish Pharmaceutical Reference Book, and this is the link to the website. The informal care, the questionnaire asked patients to state the number of hours and informal care that is given free of cost by family or friends per week that they were receiving because of their breast cancer. The data was used to assess the quantity of informal care received by breast cancer patients in different disease states. The questionnaire asked patients to state if the retirement or early retirement, as well as the reason of retirement or early retirement. Patients who were working were asked if they have been absent from work due to breast cancer during the past 3 months. Data on resource use and cost for each patient in our study sample were extracted from the electronic record at the hospital. For each inpatient episodes and outpatient visit in the electronic record, a specific unit cost was stated. These data were used to estimate the direct medical resource use and cost in the different disease states. The indirect costs were based on the human capital theory, which states that the value of the production loss is the value produced on the margin by the individual. A two-sample Wilson rank, sum, and Mann-Whitney test was used to test for differences in resource use and cost between two disease states. A Kruskal-Wallis test is a non-parametric rank analog of one-way analysis of variance. The test was used to determine for difference in cost between the different disease states. All calculations were made using Stata 8 for Windows. As a result of this questionnaire, the patient responding to the questionnaire, 21% were in their first year after primary breast cancer. 6% were in their first year after recurrency. 54% had not had a primary breast cancer or recurrence for at least 1 year, and 19% had metastatic disease. The main cost per inpatient episode was approximately around $4,300 American dollars, and the main cost per outpatient visit was approximately around $158. The average analyzed number of outpatient visits was substantially higher for each disease state compared with the number of inpatient episodes. State P had the highest number of outpatient visits with 33.7, whereas State R and State M had 29.9 and 29.4 outpatient visits respectively. State S had the lowest number of outpatient visits with 8 per year. All of the disease states had higher outpatient visit cost than inpatient episode cost, except State R. The average analyzed cost for State R was estimated to be around $9,520, followed by State M and State P with an average analyzed cost of $8,880 and $7,370 respectively. State S had the lowest average analyzed cost with $2,130. This value was substantially lower than the other disease state, and the difference was statistically significant. Regarding informal care, the average analyzed cost of informal care due to breast cancer was estimated to be around $1,040 for State P and $830 for State M. The average analyzed cost for informal care was substantially lower for State R and State S with $210 and $220 respectively. The difference in cost of informal care for State P and State M compared with State S was statistically significant. Regarding absence from work, the entire cost of absence from work in all of the disease state and age group was especially substantial in all of the disease state and age group. For age group less than 50, State E had the highest average analyzed indirect cost, amounting to $22,650. For age group between 50 and 64, State R had the highest indirect cost with $29,450. State S had the lowest indirect cost in both age group, and the difference compared with State P, State R, and State M was statistically significant. Regarding the early retirement, the share of patients who were in early retirement due to breast cancer was higher in all of the different disease states for the age group 50 to 64 compared with the age group less than 50. The total cost was substantially higher for the patient group that were younger than 65 years of age due to the high indirect cost caused by absence from work and early retirement incurred by this patient. In all age group, State S had considerably lower cost and the others than the other states. Direct medical costs were substantially higher for State P, State R, and State M compared with State S. This finding logical because curative treatment for breast cancer normally is concentrated within the year following a primary diagnosis or a recurrence, and that palliative treatment is given to patients with metastatic breast cancer. Indirect costs constitute a substantial share of the total cost of, for breast cancer patients younger than 65 years of age. In terms of limitation to this study, our selection method of using consecutive patient coming from for outpatient visit might cause a selection bias. The first year, in conclusion, the first year following a primary breast cancer diagnosis or a recurrence is associated with high direct medical costs as well as high indirect costs. Thank you for giving these opportunities.
Thank you so much. Thank you so much, Dr. Amir. It was a great talk from your side. I think you highlight cost of breast cancer. So nowadays, the cost of disease and like the treatment, it's really essential. It's like a new field in medical, and it's progress day by day, especially for breast cancer. So I think it was a great talk and highlight a lot of information we need. So if anyone has a question, please, or comment. Okay, thank you so much, Dr. Amir. So now we will go to the last session in our day, which is metastasis. So after that, after this presentation, we straight away go with the podium presentation. So thank you so much for Dr. Mani again, and we will start with him. Thank you so much.
So today we are going to talk about metastatic breast cancer. And as you can see from some of the data that I have presented here, there are expected to be almost 300,000 new breast cancer cases this year alone in the United States. Sorry, I don't have the latest numbers in the kingdom. And while breast cancer itself consists of the vast majority of cancers facing women, men are also affected by breast cancers. And there are expected to be over 42,000 breast cancer related deaths. Unfortunately, nearly all of these cases are due to metastatic breast cancer. And despite a lot of clinical efforts and research efforts over many decades right now, we are still facing the challenge of not really being able to cure metastasis. I'm showing here the number of articles, research articles, and clinical trials that have been published on metastasis which is over 373,000, and specific to breast cancer metastasis, around 64,000 articles on breast cancer metastasis alone. But unfortunately, we are faced with no cure for metastatic cancer. But I don't leave it just here, because even in just the past few years, we have had a number of breakthroughs that are giving us some hopes, actually. And I will address this in my lecture later on. So patients with breast cancer walk into the clinic with a lump or a primary breast cancer with no evidence of a spread of the disease. Some women do walk in with metastatic disease that is detectable, but the vast majority usually of patients don't have evidence of disseminated breast cancer or metastasis. So normally what happens when a woman is treated either with a surgery or with therapy is that the tissue, either from biopsy sample or surgical samples, from the tumor tissue itself is used to assess the risk of recurrence. As I told in my previous lectures, there are some grading, some staging, some molecular marker that can predict basically the recurrence of the breast cancers. Here, what I'm showing here is a very simple graph, but it's quite informative, looking at the recurrence risk of breast cancers. And this is even though it was published quite a while ago, these numbers still essentially hold true. That's if we look at the recurrence risk of breast cancer recurrence, either in patients who had mastectomy or surgical removal of their tumor with or without chemotherapy during the treatment. There are a chance of recurrence here. While the triple negative breast cancers have a high chance to recur within the first 5 years, the hormone positive other cancers, they tend to recur over very long time, sometimes more than 20 years. And this leads us to actually to ask a couple of questions and to try to predict the recurrence and use that information to treat patients accordingly. So unfortunately, when we see patients where they develop, we don't know when they come to the clinic, when they are going to have the metastasis, is it going even to have a recurrence tumor or not? And there is a huge need for detecting and knowing what are the processes that these cancer cells taking to colonize in an organ and try and form a new tumor. So I would like to talk about the site of breast cancer metastasis and the metastasis cascade. What is thought to happen or need to happen for a tumor cell from primary tumor that is growing, and in this case in the breast, is they will grow and they will form a small tumor. Then they will start to invade in the surrounding normal tissue. They will break the extracellular matrix. Then after that, they will intrafusate. The intrafusation meaning that the cancer cells right now will enter the circulation system, and they will be in a stage called transport, where they are circulating in the circulation system, the lymph or the circulation, blood circulation systems. After that, when they find the right environment, either in the brain, the bone, liver, lung, depends on the sites, they extravasate, meaning that they will exit the circulation system right now with the help of other cells. Then they will form a micrometastasis, a small tumor that sometimes it's not detectable by our current technology. However, sometimes it would take a very long time to grow, form angiogenesis, and colonize and form a detectable tumor in the distant organs. So there are sites actually for breast cancer metastasis, and in this case we call it organotropic. So usually the known sites for breast cancer metastases are brain, liver, bone, lung, and also distant lymph node. And what we can usually see is that the triple negative breast cancer tend to metastasize to the brain, liver, and lung sometimes. But the hormone positive, usually they tend to metastasize to the bone. So there are some factors that contribute to this. There are some signature that might attract for these cells to grow in those specific organs. However, there are still very huge amount of questions that we have to answer and to understand why these cells specifically metastasize to those organs and why they selectively grow in those organs. One of the speculation is that there are sufficient or enriched environment with growth factors that these cells will need to form the micrometastasis, then after that the macrometastasis and the colonizations to be able to be detected by the current imaging techniques. So studying breast cancer in metastasis, studying breast cancer metastasis in the laboratory, how we address this issue, because this is a complicated process that it's happening over many years. So one of the techniques that is used in the lab is basically using cell line derived from patients. And one of the most famous examples, although it's not from breast cancer here, it's from cervical carcinoma patients, is HeLa cells. This is a cancer lines that derived from or obtained from patients in 1950s, and it's still being used in the laboratory till today. Unfortunately, at that time, patients were not even consent for getting her sample to be cultured and used for the research, but it's still a powerful technique actually to study the key molecules and the key pathways that contribute to the metastasis. Sometimes the scientist and the researcher will be able to engineer the normal human breast epithelial cells. They will try to make some genetic alterations for these cells that they will behave right now as cancer cells. And this is by deregulations of key pathways that have been shown to associate with the development of breast cancers. Another important model is the use of patient-derived xenograft, and this is actually a very advanced model, which is actually very powerful because it's mimicking the microenvironment that you can see in the patients, although it's not totally mimicking that, because most of these animals, they are immunocompromised. But at least we can take the tissues or the cells from the patients. We injected in a first generation of breast cancer pediatric xenograft or patient xenograft, sorry. Then after that, we can transport these tumors in several generations of mice. And in this case, in most of the cases, it's maintained the heterogeneity that we can see in the original tumor. So this is a very powerful technique. However, there are some technical limitations. You need to have very huge number of animals. You have to have animal hospital if we consider that as a hospital, a very good animal facility, very connected team to take the samples freshly from the patients, inject it in the animals and maintain it in the animals and see the progression of the tumors in those animals. Another topic is basically using the immunocompromised animals. And this is very also powerful technique, although sometimes the immune cells reaction is not it's not fully understood here, because most of these animals, they don't have or they don't have some or major part of their immune system present in this case. So it will be able us, we are deleting those cells to enable us to engraft the cancer cells here. But it's powerful techniques that used in many labs right now to try to understand the metastatic process. So another interesting model, which is using transgenic mouse models to study breast cancer. And in this case, scientists will try and make mouse models that will generate breast cancer spontaneously. And in this case, there are lots, you can see here, lots of animal models that were successfully showing metastasis to different organs. So the primary tumor will metastasize to different organs, either lung usually here, but it can be to liver and brain and other organs. And you can see in some of them actually, there are degree of time that the metastasis will happen, which is mimicking the things that we see in patients. So patients usually, as I mentioned before, it takes time sometimes to, especially with the hormone positive cancers, to develop a recurrence or relapse. However, the triple negative, usually this happens in the first 5 years. This is again showing different models that has been used in those animals. The injection of the cancer cells in the animals actually is really important because it will determine which step that it will be addressed. So, for example, if it's injected in the tail fin, the scientists, they are injecting in the tail fin of a mice. The patients, they are trying to start studying how the cells extravasate from the circulation system and home to a certain organ, and then after that start to grow. So there are different techniques that the scientist and the researcher using in different labs to really understand what are the key processes that enable those cells to grow in distant organs. And some of the techniques, some of the injection type will be able to really shed a light on the process that happens in every single steps. For example, extravasation, intravasation, and so on, and the formation of the relapse. So I'm showing this again because this is a really important cartoon here that I showed before, and why I'm showing this because to actually appreciate the complex process that the cancer cells has to go through to be able to metastasize to a different organ. So then after that, I would like to mention the metastatic niche, which is the microenvironment for those cells to be able to grow in a certain organ. So the idea of the metastatic niche is not very recent hypothesis actually, but it was proposed very long time ago by this gentleman, Stephen Budget, where he observed that some cancers, they have organotropism, that they can metastasize and form tumors in different organs. He studied over 900 autopsy cases, and he found that, for example, breast cancer tend to be metastasized to brain, lung, liver, or to the bone. And also he observed the same thing for other cancers where they have the ability to metastasize to specific organs, and it's not a random thing. So he proposed the soil, the seed and soil hypothesis, where he basically thinks the cancer cells are the seeds and the microenvironment, the tumor microenvironment are soil. So the cancer, usually the cancer cells disseminate from the primary tumor and try to find the right soil. And in this case, it would be the right organ, and that will then form micrometastasis. And with the time and with the help of other cells in the microenvironment, they will form the macrometastasis. So as I told, the cancer cells is interacting with the tumor microenvironment. This is including some of the immune cells, some of the stromal cells, and also some of the endothelial cells to form angiogenesis, new blood vessels that supply this new tumor right now with the required nutrition. And they will serve as factors for growing the tumor, and in some cases even to protect the tumor from the targeted therapy. So again, for breast cancer, there are interaction with specific organs, and this is where we talk about the organotropism. So the triple negative, for example, to metastasize mainly to the brain, lung, and liver, while the hormone positive tend to usually metastasize to the bone. And there is also interaction between the tumor cells and the cells in the microenvironment. So there is an interaction that will allow, for example, the cells to cross the blood-brain barrier. And also there is the same thing for in the lung and in the bones. And this is not only on the cellular level, but also on the molecular level. So the cancer cells will interact with other cells in the microenvironment, in different microenvironment, to release some factors and to regulate some pathways that will help them in growing and expanding and form micro and then after that macro metastasis. So they can excrete or secrete some extracellular vesicles that enable them to permeabilize, for example, the blood-brain barrier and to allow them to enter the brain microenvironment and to form tumors. They also secrete or interact with the microenvironment to secrete some factors that will allow the extracellular matrix degradation and forming the invasion of these cells in those microenvironments. So there are lots of factors and lots of molecular pathways that taking place in every single organ that the cells will metastasize to. So there are also other factors. It's not only the soil and soil, but also the weather, if you say, the weather, which is other factors that contribute to the systemic regulation of metastasis. And here is an example of modeling early metastasis dissemination. So this scientist here, this paper showed that primary tumor, when they labeled them with GFP, so this is green fluorescent protein, that will enable scientists to visualize the cancer cells later on when they injected in the animals. So when they injected control cells, weekly control, cells that they are not usually metastasized in combination with matrigel, they didn't basically see that much of colonization in the lung, except few cells here. However, when they take primary tumors from a patient and they label it with GFP, they engineer it to express this green fluorescent protein, and they monitor the cells over time, they found that there is a huge number of cells right now, the green fluorescent cells here right now that's growing right now as micro metastases in the lung of the animals. And you can see here, this was done by injecting into the tail vein. So the cells will go right away to the circulation. Then after that, the cells will be forming those, will take time to form this. You can see it here by the day of 84. After almost 3 months, you can see that there is a growth of metastasis colonies in the lung of the cells with the primary tumors. So this is again giving us a way of understanding how these cells right now be able to metastasize and form micrometastases in different organs. So usually the primary tumor cancer cells will release some factors that will actually hijack, if you say, or educate other cells, other normal cells, to help them. In this case, the bone marrow cells, they will be pro-tumorigenic, and they will help them to basically metastasize to different organs. So they will home to different organs where they will also interact right now with other cells in the microenvironment. That will help them to form the micrometastasis, and they will be sometimes maybe dormant. We were not able to detect them by the current imaging systems. Then after that, in the presence of a specific trigger, the cells will start to grow and relate, and they will form clinically metastatic disease that can be detected using the current imaging systems. So there are other factors that can help also the metastasis, and we call it here the weather. So other factors such as aging, obesity, and using some the stress exercise sometimes, unfortunately, they can contribute to the metastasis of the breast cancer cells. This is some of the studies, although there are studies that suggest that cancer cells are metastasizing from the day that they are forming the primary tumor. However, they will take time to be detected. So there are lots of controversy also about when the metastasis is happening. Are these factor is really contributing, or a key contributor, or they just tend to be just a contributor that it would be vary from patient to another. So there are new strategies to study and target metastasis, and these are giving us a new hope. And as I mentioned earlier, we have some new hopes. And here what I'm showing you is the patient who was diagnosed with her negative primary breast cancer. Unfortunately, the patient developed metastasis, as you can see in the whole body scanned here. So there are metastases in the liver and in some of the lymph nodes, and it's very clearly that the patient is having very huge degree of metastatic tumor. So the patient developed severe skeletal metastasis, as you can see something also here also in the liver. And with the approach by linking the anti-HER2 drug, the trastuzumab, with an imageable tracer to direct the drug to the tumor cells that are disseminated through her skeleton. The clinicians right now, they could localize and visualize the tumor cells that have disseminated. This patient then underwent HER2 therapy. Again, her primary tumor was HER2 negative, but the data clearly show that her metastases are HER2 positive. So that enabled clinicians to treat her with HER2 targeted therapy. And this is also talking to the heterogeneity that I was talking about in the first lecture. So after the treatment, and even within 3 months, a lot of her tumors had regressed or been cleared. So this is offering us a new hope that if we understand really the metastasis and the metastasis processes will be able us to treat patients differently. And we can change the clinical management based on the type of the case and also the degree of the metastasis. So I will conclude here, and in this presentation, I hope I convinced you that breast cancer is a major clinical challenges. There are lots of efforts that has been done all over the years in the past, and there are new hopes for treating patients with metastatic cancer. Metastases usually occur in a very regulated manner through different processes by disseminating from the primary tumor to extravasate, extravasate, and after that forming small tumors in distant organs that can be later on grow as large metastatic tumors. There are organotropism for some type of breast cancers, and some breast cancers type they tend to metastasize to the brain, some to the bones, and so on. We know that there are different models that has been used to study metastasis. With the animal models is one of the greatest tools actually that are used in the labs to understand the process that that control the metastasis of these cancer cells. As I also mentioned, there is a good improvement in treating patients with metastatic cancer, but again, there is also a huge need of improvement, and we need to really understand how we can change the management protocol or the clinical protocol sometimes to be able to give the patients the right treatment. With this, I would like to thank you, and I will be happy to answer any questions. Thank you so much.
Thank you so much, Dr. Mana, of the really great lectures you gave. And also, we would like...
Thank you so much. Dr. Mashari will be a chair of this session, Dr. Mana. It's a great talk. And I just would like to mention to the participant for podium presentation, it will be start straight away after finish the question session with Dr. Mana. Go ahead, Dr. Mashari. Thanks.
Okay, Dr. Mana, I have too many questions. Maybe we will start at the beginning from the previous lectures. Dr. Hussam Ganesh asked about, have you ever looked into the hematological parameters in relation to the breast cancer? If so, what are the most significant markers that can be used to indicate the late stage of the cancer?
Well, thank you so much, Hussam, and thank you, Dr. Mashari, for the questions. So no, unfortunately, we didn't look at the hematological parameters that Dr. Hussam is interested in. And those markers usually, or parameters usually different and vary based on the treatment that the patient is receiving. So we didn't look specifically on any of these parameters, to be honest.
Okay, so in terms of clinical treatment, do you have a plan in your lab to use the IPSC technique? Also, that's from Dr. Hussam.
Well, from Dr. Hussam, so the induced pluripotent stem cells, so there are lots of efforts to see if there is any way that can be used in treating some diseases. There are some attempts to use them in treating, for example, myocardial infarction. But in breast cancer, for specifically, there is no, at least clinical evidence that these cells would be used in the clinic so far. There are some scientists, even in our center here, that they use some of the supernatant and they try to model the cancer cells or trying to use the excretion of some marker, some of the condition media when they culture it with other cells and try to put it on the cancer cells to see if they can affect the growth of that. But again, we are not using this specifically in my lab, but there are some colleagues that they are doing so.
Excellent. Is there any other question? Also, Dr. Hussam, he has another question, but I cannot give him the mic because of the technical issue. If you like to write it, and we will deliver it to you, Dr. Mana. Is there any other question?
Hello, doctor. Could you hear me now?
Yes.
Oh, thank you so much, Dr. Mshari, and thank you for giving me this chance to ask Dr. Sherry for the great first presentation, followed by wonderful work in the second session he did. If you have said that there is it's like a challenge to treat the breast cancer so far. But my concern is about is there any way to block the B53 in order to decrease the replication of those cancerous cells? The B53 has a very important role in it's like stop the circle for some time. It might be like an inhibitor to use to transiently just block this B53.
Yes. So the B53 in general, it's called the garden of the genome. So it's controlling lots of important processes responsible for the apoptosis, survival for the cells, and it's one of the most mutated genes all over the cancer. So it's not only breast cancers, but you find it in colon, brain, and different cancers, which is highly mutated. There are some attempts to target P53, but the problem with most of the cancers that it's not only one pathway that you can be able to target and you will inhibit. Usually, it would be lots of mutations or alterations in different pathways that will help the cells to survive some treatments. So there are some methods that, the chemotherapy in general, for example, they tend to do breaks in the DNA that the cells that they can't tolerate, then after that they will die. And this would be with either the P53 positive or negative. So there are some attempts, but I'm not aware about specific inhibitors to use against P53 alone that lead to improvement in the clinic.
There is one inhibitor that's being used. I already used this during my PhD. You can get it from a Thermo Fisher. It says it's great, to use it. It's great to try it for your research, because you have almost like very good, outcomes so far. But you can use it in ex vivo and might be applied to clinical.
Yes. I totally agree that there are some molecules and some inhibitors that can be used in the preclinical studies, but I was mentioning this for the clinical practice. So there are lots of inhibitors targeting different molecules in the preclinical stages, but some of these, they are not across the clinical trials, the phase 1, phase 2, 3, and used in the clinic. But you're right, there are lots of molecules, and actually targeting B53 or for example RAS, that it's also mutated in most of the genes. It's a golden technique, and right now I'm aware about at least a molecule that has been approved by FDA, the US FDA, to target, for example, RAS, and it has showed very promising results with some types of lung cancer. And the question would be, unfortunately, it didn't show the same promising result in colon cancer with mutant RAS, for example. So sometimes, even if you have a mutation in one gene that you can target it in one cancer and it respond very nicely, it's not necessarily that you will be able to find it working really well in the other cancers. But I totally agree with you. P53 is an important target that can be targeted for treating some cancers.
Yes, you are right that the cancer is always like a complicated story, among all different cancers. Thank you so much. I really appreciate that.
Well, thank you so much for the questions. Thank you.
Thank you, Dr. Hussam. And we really appreciate your time, Dr. Manner.
Thank you so much.
Right now, we will move now to the next session. Thank you so much, Dr. Manner.
Thank you so much. Thank you, everyone.
Okay, now we will go to with Abdul Wahab Al-Amri. Abdul Wahab Al-Amri. You can share screen, Abdul Wahab.
السلام عليكم ورحمة الله وبركاته. Believe that my screen now is sharing okay.
It looks okay, but okay, right now it's okay.
السلام عليكم ورحمة الله وبركاته. This is Dr. Abdul Wahab Al-Amri, Assistant Professor and the Head of Pharmacology and Toxicology Department in the College of Pharmacy, University of Hayl. I am glad to have an opportunity to participate in such scientific conference, to learn a lot and to share a bit of what we have done as a group, worked on docking basal or based virtual screening and identification of potential anti-breast cancer molecules from marine sources for population from Hayl region. First of all, as previously mentioned by a lot of scientists being participate in this conference, breast cancer is the most common of all cancers internationally, regionally, and nationally, and the most common cancer among women in the Kingdom of Saudi Arabia, especially those of age 40 years old or more, and accountable for about 2 million new cases and above 500,000 deaths annually worldwide. Most of the cases, unfortunately, diagnosed at late stage, while breast cancer can be cured in about 70 to 80% of the patient at early stage. Breast cancer, as known, is multifactorial disease, and among various factors, genetic and hormonal factors have been implicated in the genesis of breast cancer. Estrogen plays a critical role in the growth and development of bone, breast, and uterine pathology. And some breast cancer cells need estrogen to grow. And when estrogen attaches to a special protein called estrogen receptors, the cancer cells with these receptors grow. And so there are two subtypes of estrogen receptors as known, which is estrogen receptor alpha and estrogen receptor beta. While these, the alpha 1 or estrogen receptor alpha plays a role in cell proliferations and has been found in the endometrial breast cancer and ovarian stromal cells, as well as in the hypothalamus. Tamoxifen as a selective estrogen receptor modulator is the most used anti-estrogen adjuvant treatment for estrogen receptor alpha positive premenopausal women. However, despite this medication beneficiary, it has serious risks, which is represented in the risk of endometrial malignancy and hyperplasia. Endometrial cancer increased significantly with overweight post-menopausal women and natural resistance to hormonal therapy. Therefore, alternative treatments are in need. Marine drugs are a kind of natural product which are obtained from the marine species, either bacteria, virus, fungi, and there are too many kinds, while the greater number of compounds, marine compounds or marine drugs, till nowadays obtained from sponges. Interest of marine drugs has increased significantly among researchers during the last 2 decades, when the expand of published work in the previous 2 decades is obvious. And marine drugs become a top spot for the identification of new drug leads, while this attributed to a large variety of compounds with quite unique chemical structures that these products produced. It's also ascribed to the abundance of these products with lead compounds in addition to other features like its affordable cost and sustainability, and as well as good pharmacological potential. And this slide, we can see the approved medications derived from marine sources and being used as therapy for different types of cancers and some other diseases. Cytarabine, for example, is the election drug for the treatment of myeloid leukemia, non-Hodgkin's lymphoma, and meningeal leukemia, and could be used alone or in combination with other anti-cancer agents. However, its limited extraction yield from marine has sent the source economically unfeasible, while it's manufactured these days by structurally. The Riplium as well, the Riplium mesylate, or what we know it as Halavin, is a product isolated from marine sponge known by Helicondria ocadi, which is indicated for the treatment of patients with metastatic breast cancer with some medical requirements to be prescribed. Okay, our work was conducted using docking-based virtual screening, which is one of the techniques used prior to the in vitro and in vivo techniques. During this screen of 450 cancer marine compounds was done via protein data bank using RCSP website. 3D structure of estrogen receptor alpha in a complex with 4-hydroxy-tamoxifen as a metabolite or metabolism of tamoxifen was selected for virtual screening. The hydroxy-tamoxifen was the co-crystallized ligand as a standard. Using molecular operating environment doc program, targeted dataset was subjected to docking-based virtual screening. The binding energy and the description of the protein inhibitor interaction, as known, are very benefit or give beneficial results for further experimental and theoretical studies. While the less is the binding energy, the more efficient for inhibition is the substrate or the compound. And the compounds were ranked by the score of GBVI, which is generalized Born volume integral binding free energy calculations in kilogram calorie per mole. And the compound with binding energy values less than minus 9.5 kilocalories per mole were considered best for the inhibition. And only top 7 structurally diverse scaffold were selected for further analysis. This slide and the following one demonstrate the compound or the compounds, which tricky to pronounce, ideally, to be honest, along with the chemical structures of these 7 compounds and the binding energy that are apparently was minus 9.5 or less for all of these compounds. The next couple of slides illustrates 2-dimensional interaction plots of these compounds with amino acids of estrogen receptors, as can be seen This is the compounds, and these are the amino acids. It's the same, but with different shape. So these are the amino acids, and this is the compound itself, and how these compounds link to amino acids of the protein in all 7 compounds that we pick. Lipinski's rule for determination of drug likeness states that, and in general, an orally active drug has no more than 1 violation of the following 5 criteria or rule, which is the compound to have a molecular mass of 500 Daltons or less, and the compound should have a nocturnal water partition coefficient, which is known by log P, that does not exceed 5. It also, the compound has no more than 5 hydrogen bond donor, which is the total number of nitrogen-hydrogen or oxygen-hydrogen bonds. And the compound also not to has more than 10 hydrogen bond acceptors, which is the net of nitrogen and oxygen atoms in all the compound. Also, the polar surface area not to exceed 140 angstroms. And thanks to Molinspiration websites, which has helped us to run this kind of investigations, to experiment or to investigate whether the compounds could pass this 5 criteria to consider as effectable as orally dosage form. This slide demonstrates the pharmacokinetic, which is the absorption, distribution, and protein binding properties of these 7 compounds that inhibited the estrogen receptor with less than minus 9.5 kilocalorie per mole. And as can be seen in this table, there are a lot of values, which is the gastrointestinal absorption, brain-blood barrier crossing ability, inducing carcinogenic effects, and plasma protein binding values. And as per Lipinski's rule of 5, the gastrointestinal absorption of all compounds had good absorption except for the one with minus value, which is the myrmecosides E1, and high absorption predicted for the compound on the very bottom of the table, which is isobutanediol, and excuse my pronunciation for these chemicals, but this is with maximum value of absorption. Vancomycin E and myrmecosides, these 2 has not good outcome in terms of blood-brain barrier penetrations. And we can see here the plasma protein bindings value, while protein binding can influence the drug's biological half-life, and the bound portion may act as a reservoir or a depot from which the drug is slowly released as the unbound form. Since the unbound form is being metabolized or eliminated from the body, the bound fraction will be released in order to maintain equilibrium. This table demonstrates again the Molinspiration calculation and drug likeness rules as discussed earlier. The compound with lower volume demonstrates likeness to have good absorption and distributions. We mean this term of values. The values in here also shouldn't exceed 500. When it exceeds 500, it can't be used as an orally dosage form. So as per this rule, compound of homophosphorylate A, that's 1, has the better value, so had better profile as well. And as can be seen, these 2 compounds, which is myrmecosides and vancomycin E, violated more than one Lipinski's rule, so they can't be accepted as orally dosage form, while they might be workable or applicable for another forms. To sum up, 7 marine compounds exhibited best docking score, which valid them to be potent anti-breast cancer compounds. The bioactive potential and promising drug likeness profile of these compounds make them valid leads for further experimental research. And the study compounds suggest that they could be either used as drugs or as a functional food ingredients with a promising role in formulation of medicines and nutritional supplements. And future views could be the development of new functional ingredients food based on mechanistically proven evidence or efficacy, and also in vitro and in vivo screening, lead optimization, and bioavailability. Finally, these are some papers that have been published by our collaborators in this project. And this is the end of my presentation. Thank you to all.
Thank you very much, Dr. Abdul Wahab, for your interesting presentation. And if you allow me, I have one comment. From your observation, did you notice any conserved residue making interaction with ligands?
Sorry, I didn't pick that very good, doctor. Would you mind to say that again?
Sorry. In your observation, did you notice any conserved residue making interaction with ligands from the compounds?
We, doctor, focus on the compounds on the databases. So we took that based on the computerizing system and only looking for something with critical values. So if it's not apparent or give us below the threshold that we bought, we didn't investigate them in detail.
Okay, what types of interaction are mostly presented in the docked complexes in your system?
Well, this is tricky questions to be answered, to be honest. But we make the standards for our Legend complex combination as hydroxytamoxifen. We make that crystallized or co-crystallize and compare the new compounds with it.
Okay, perfect. Any question?
Excellent. Thank you, Dr. Wahab. Thank you so much for this great lectures. Thank you, Dr. Amir. So we will move now to Razan Al-Amri. Go ahead, Dr. Razan. You can share screen, Dr. Razan.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Good afternoon, everyone. It is a pleasure to be able to speak to you all today. My name is Razan Al-Amri. I am a master graduate from Taiba University specializing in molecular biology. And I am currently working as a research assistant in Center of Genetic and Inherited Disease of Taiba University.
Okay, thank you. I would like to, thank you. Go ahead.
Over 70% of estrogen receptors alpha, over 70% of breast cancers are estrogen receptors alpha positive at diagnosis. And the estrogen receptor genetic variations have been reported to be functional and maybe contribute to genetic susceptibility to breast cancer. So our presentation is titled Estrogen Receptor 1 Gene, BOVI Polymorphism and Breast Cancer Risk in Saudi Women. Breast cancer is the most prevalent cancer among Saudi women, causing changes within the body cells and leading to uncontrolled cell growth. In 2018, WHO reported that breast cancer among Saudi women accounted for 29.7% of the most diagnosed cancers. Increased risk of breast cancer is associated with exposures to high concentrations of estrogen hormone. effect of estrogen are mediated through two distinct nuclear receptors, estrogen receptors alpha encoding by ESR1 gene and estrogen receptor beta encoding by ESR2 gene. Estrogen receptor 1 gene located in chromosome 6 encoding estrogen receptor alpha consisting of 8 exons and 7 introns. ESR1 serves as a ligand-activated transcription factor and is capable of binding both endogenous and exogenous hormone in order to drive cell proliferation, control cell growth, and control programmed cell death. One of the most characterized SNPs of ESR1 is BOVI restriction site polymorphism located in the first intron. BOVI was found to be associated with breast cancer risk and other diseases in which the estrogen is implicated. Possible functional mechanisms attributed to this polymorphism include a change in the expression of ESR1 gene by altering the binding transcription factors and affecting alternative splicing of ESR1 gene. The aim of the study are first to investigate the possible role of ESR1 genes BOVI polymorphism in susceptibility to breast cancer. In addition to evaluate the association of this polymorphism with the presence or absence of estrogen progesterone receptor and a human epidermal growth factor receptor 2 and menopausal status. Material and method. First of all, the study was approved by ethics committees of Taiba University and King Fahd Hospital. Tissue samples of Saudi women were collected from King Fahd Hospital. All samples were archived and anonymous, formalin fixed and paraffin embedded tissue from the years of 2011 to 2017. And the retrospective hospital-based control study, including 137 histopathological confirmed cases and 98 control samples. DNA was extracted using the modified phenylchloroform protocol. Then, ESR1 gene's polymorphism was genotyped by PCR RFLB using the BOVI restriction enzyme. For further confirmation, two samples with different genotypes was sequenced at Macrogenes company. Finally, genetic associations tests were performed with Shachet software. Result of discussion. The genetic analysis results showed a similar distributions of T and C alleles in cases and controls, and p-value was 51. Besides, the genotype frequencies indicated that no significant differences in cases and controls, and the result showed no significant association with breast cancer risk. Genetic association of ESR1 polymorphism with breast cancer is contradictory in different studies. The possible explanations of how breast cancer risk is affected by the intronic BOVI polymorphism of ESR1 gene includes that some introns contain regulatory sequence such as enhancer, which affect the level of expression through transcriptional regulation. The intronic polymorphism may be in linkage to equilibrium with exonic SNP that affect ESR1 protein function. And the polymorphism may be linked with another unidentified gene that adjacent to ESR1 gene, which increases breast cancer risk. The certified analysis based on menopausal status, the result didn't find any genetic associations between the menopausal status and increased the risk of breast cancer. Differences in menopausal status are indicated to have an impact on estrogen synthesis, metabolism, and signal transduction. Several meta-analysis studies indicated that the ESR1 polymorphism places the premenopausal women at risk for breast cancer in contrast to their postmenopausal counterpart. So, the ESR1 polymorphisms may be influenced by breast cancer development. Development via regulating the time of menopause. The BOVI polymorphism was reported to be associated with estrogen receptors or other receptors expression in breast cancer patients. But there is no significant association was found in our result with the presence or absence of estrogen and progesterone receptors and HER2 in tumor samples. This is the first study conducting case A, investigating ESR1 genes, BOVI polymorphism, and breast cancer risk. And there are many case control studies that have been conducted on different populations. However, the association between the ESR1 genes, polymorphism, and breast cancer risk is still not clear. It is likely that the tumorigenesis of breast cancer is affected by many factors, such as age, ethnicity, lifestyle, and even environmental factors. Conclusion of our study result indicated that there was no association between the BOVI polymorphism and susceptibility to breast cancer in Saudi population. Ethnic differences and environmental factors that vary among populations may affect the associations between the SNPs and the risk of breast cancer. Our recommendations is further study to confirm this finding in populations-based case control study in Saudi Arabia and more polymorphism within the ESR1 genes could be included. Thank you everyone for listening.
Thank you so much, Ustad Razan Al-Amri. Lectures. Dr. Amri, is there any question? Or the audience, if there is any question, go ahead.
Like Dr. Hussam has a question.
Dr. Hussam.
Dr. Hussam.
ايوه يا فندم السلام عليكم.
الدكتور حسام دكتور حسام موجود. عليكم السلام. I think the mic with Dr. Hussam, please.
Okay, thank you so much, Dr. Razan, for the great presentation. When you do the DNA sequencing, do you include all the intronic exons for both genes, or?
There is one SNP in one gene. Just one SNPs.
Oh, just one SNPs in one gene.
Yes,
Okay.
BIVV SNP.
Oh, okay, makes sense. Yeah, that's the only question that I was concerned about. Thank you so much.
Welcome.
السلام عليكم.
وعليكم السلام.
تفضل دكتور هشام، المايك معك.
اتفضل يا فندم. انا بحاول بعمل شير سكرين بس في مشكله واضح عندي في البراوزر.
لحظه دكتور، لا تعمل شيء سكرين لما نخلص من الاخت.
طيب يا فندم، اسف، عفوا.
Go ahead, دكتور مشاري.
Is there any other question? Okay, let's move to next presenter, Dr. Hisham. Thank you so much, Razan. Thank you.
Welcome. Thank you for you.
Go ahead, Dr. Hisham, and you can share screen now.
Okay, I'm trying to share screen, please. One moment.
Try now.
دكتور هشام، تحتاج تفتح السلايد عندك وبعدين تسوي شير سكرين ويطلع لك خيار اخر ترفع البرزنتيشن حقك. شكرا.
As I know, the best way to do it is open the slides first, then share screen. Stop sharing now and open it, please.
شكرا دكتور هشام. انت تحتاج تفتح السلايد، ما تدخل على الملف كذا، يكون السلايد مفتوح، يعني تفتح تشغل الباوربوينت بعدين تدخل على الشير السكرين. شكرا.
Dr. Hisham, are you with us? Dr. Hisham? I'm not sure if he hears us or no. So if he is not ready, do you hear us, Dr. Hisham? Okay. Dr. Hisham, please unmute your mic.
I send request to go. Yes, good. Unmute Dr. Hisham from your side. Accept the invitation. So Dr. Mishari, go with the second one, then you go back to Dr. Hisham if it's working again. Thank you.
Okay. Dr. Najwan. So we will go now to the Dr. Najwan, which also she will talk about awareness of breast cancer, risk factors, and avoid among high city population. So Dr. Najwan, are you with us now? Do you hear us?
Yes.
Excellent. Dr. Najwan, just
Okay.
please open the PowerPoint first before you doing sharing.
Okay.
Dr. Hisham, if you don't mind, just stop sharing now. We will fix it together. Thank you, Dr. Hisham. We will try to fix it. Just enlarge it, please.
Okay. Assalamu alaikum. I'm Dr. Najwan Al-Hussein, Assistant Professor in Diagnostic Radiology Department, College of Applied Medical Science, University of Hawaii. Our study is about awareness of breast cancer risk factors and its avoidance among high city population. Breast cancer is the most common malignancy and the leading cause of cancer-related deaths among women worldwide. While the exact causes of breast cancer may not be fully known, some risk factors have been observed to affect the development of breast cancer. These risk factors fall into two categories: non-modifiable and modifiable. Non-modifiable risk factors refer to conditions that are out of our control and cannot be altered, while modifiable risk factors can be changed through action and decisions we make. The non-modifiable risk factors include gender. Gender is the main risk factor for breast cancer. Men can get breast cancer too, but this disease is much more common in women than in men. About the age, as you get older, your risk of breast cancer goes up. According to recent study, most breast cancer are found in women aged 55 and older. Women with dense breast in mammogram have a risk of breast cancer that is about 2 times than women with average breast density. According to the family history, having a first-degree relative like mother, sister, or daughter with breast cancer almost double women's risk. A woman with cancer in one breast has a higher risk of developing a new cancer in the other breast or another part of the same breast. Modifiable risk factors is the lifestyle-related risk factor, which include alcohol consumption. Drinking alcohol is clearly linked to an increased risk of breast cancer. Also, being overweight or obese, especially after menopause, increase breast cancer risk. Not being physically active also can increase breast cancer risk. Some studies have found that heavy smoking over a long time might be linked to a higher risk of breast cancer. Not breastfeeding is one of risk factor of breast cancer. The hormone replacement therapy. This hormone therapy with estrogen has been used to relieve symptoms of menopause, can increase also risk of breast cancer. Prevention has been prevention prevention has been recommended, and it is decrease the burden of breast cancer. These are things you can do that might lower your risk, like limit your alcohol intake, exercise regularly, avoid or quit smoking, maintain healthy weight, adopt a healthy diet, while limit hormone replacement therapy. The significance of this study is increase in awareness about risk factor and risk reducing strategies are important for the primary prevention of breast cancer. So the aim of this study is carried out to determine the awareness of breast cancer risk factors and its avoidance among high-city population. This is cross-sectional study design conducted among 914 participants living in high-city Saudi Arabia. The data was collected by structured questionnaire. This questionnaire has been distributed via social media and contains a set of questions to collect information of socio-demographic data, breast cancer risk factor knowledge, and prevention awareness. The data were analyzed using SPSS program, and the data were presented in tables and graphs with chi-square. About the socio-demographic data of participants, the common age of participants is between 21 and 35 years by percentage 50.4. Most of participants were female, per percentage 98.4%. Most of participants were university educated by percentage 70.9%. Due to lack of time, we will present some important questions were asked to the participant. We asked the participant about the strongest risk factor of breast cancer. 30.7 participants answer the genetic is the strongest risk factors of breast cancer. Result consonance with Hamid, 2018. They reported family history of breast cancer is one of the major risk factors. Also, this result not consonant with the finding of Dura 2015, which showed the strongest risk factor of breast cancer is age. .1% of participants considered the smoking is a risk factor of breast cancer. This result goes in parallel with Ali Rashidi, 2017. They reported 75.6% of the study subject choose smoking as a risk factor of breast cancer. Knowledge of participants about the prevention from breast cancer was low because 32.9% of participants didn't know the way of prevention from breast cancer. This result was in disagreement with the study reported by Aydogan in Turkish women, 2015, which showed 60% of women had sufficient knowledge about breast cancer prevention. Finally, we asked the participants about the diagnosis method of breast cancer. 93.3% of them, they know the breast cancer diagnostic method. This result was disagree with Dura. 2015, they reported that the majority of the participants had never heard about breast diagnostic method. The result of this study indicated that most population aware about the breast cancer risk factors. However, the awareness about the breast cancer prevention were inadequate. Finally, we recommended that the level of knowledge about prevention should be raised among high population to avoid the breast cancer, particularly in low-educated persons. Classification of women based on risk factor for breast cancer can be effective in improving methods and designing targeted breast cancer screening program. Knowledge about diagnostic method is highly beneficial to the participant as it assists women regarding when and how to perform breast cancer screening for early detection. Thank you.
Thank you so much for these lectures. I have a question. Dr. Antoine, have you, I'm not sure, I'm not focused a little bit, but what is the most identified risk factor in high region?
Genetic factors.
Genetic factors.
Yeah.
Because
It's
comparing
according, this is according to the participant cancer.
When we try to compare it to other studies, most of the studies show that either alcohol drink or family history. So in higher genetic. Okay. Other question: do you have you used any statistic like SPSS software?
What?
Have you used any software statistics?
Yes. We use the SPSS program version 23.
Oh,
Also, we make a correlation between the education and knowledge about the risk factor. There is significant correlation, especially in educated persons.
Okay. So, do you know the mean for the participant knowledge level about breast cancer in higher?
Not exactly.
Okay, in progress. Okay. Any other question, please?
I have one question, if you allow me, Dr. Mashari.
Go ahead.
Dr. Najwan, the sample size, the samples, the participants in the study from high city only, or all high area with the
not high city only, not high regions, just high city.
Okay. Thank you.
Any other question? Professor Abdul Mun'im. Go ahead, Professor Abdul Mun'im.
Yes. Assalamu alaikum wa rahmatullah. Thank you very much, Najwan, for this nice presentation. I have two questions. My first question, with the exclusion of big cities like Riyadh, Jeddah, and Dammam, is the incidence in Hail comparable with other cities like Al Jouf or like Jazan or different?
Yes.
Do you have any data about that?
No, just our study or our research just in high regions.
No, I mean in comparison with previous studies. Is there any previous studies regarding Jazan or Najran or Jouf?
Yes, there is. There is previous study, but about prevention, there is no. I didn't find any study about prevention, but about risk factor, yes. To compare, in Riyadh, the risk factors is age. Yeah, the participant asked age in the Riyadh.
Yes.
Yes, but I didn't find any research about prevention.
Okay. Actually, there is another question also, if you allow me. There are three lifestyles issues that related to the breast cancer.
Yes.
First one is at the first birth. Nowadays, females get married at older age than before.
Yes.
And number of children also. Now people just limit the number of children, and people avoid also breastfeeding. And this always going with the lifestyle and level of education of the female.
Yes.
How can we overcome these obstacles? I mean, to maintain good lifestyle while reducing the risk factors.
Yes, we recommended the breastfeeding, and we asked also the participants about the late marriage. If is it one reason of the risk factors, most of participants agree that. Also, we ask about the pills, the control birth pills.
Yes.
Yes. Is it one also of risk factors? And breastfeeding. we highly recommended to breastfeed for 2 years, to prevent from breast cancer.
Okay, thank you.
Thank you, Mr. Abdelmanan. Is there any other question? Okay. Thank you so much, Dr. Najwan, for this lecture. And we will move forward. Thank you, Dr. Najwan.
Thank you.
So we will be back to Dr. Hisham with us, Dr. Hisham.
Yes, sir. I hope I'm ready. Okay.
Excellent. I think I'm not sure if you do it in our ways that we should to download the Zoom. If you have it, okay, right now. So do you hear us now, Dr. Hisham?
I'm trying. Okay, now I'm coming.
Okay, just enlarge it if you can.
Excuse me, sir?
Just enlarge it. I mean, just put it in a presentation mode from the corner.
I'm sorry, but I have a very strange message that I'm sharing another application on the Windows, but I'm not sharing anything.
What is the message saying? Do you use the website or the application? Do you download the application in your computer? Dr. Hisham? We will give Dr. Hisham 1 minute to try to figure it out.
Can you go to second slide, Dr. Mashari? Can you go to second slide, Dr. Hisham? Can you go to second slide? Yes, just explain. It's fine for us. We can see it.
Okay.
Yeah, just let him finish, Dr. Hisham.
Go ahead, Dr. Hisham. Dr. Hisham?
Dr. Hisham, do you hear us?
He has the mic, but something wrong going with him.
Dr. Hisham, can you speak? Can you speak, Dr. Hisham? Okay, Dr. Mashari, go to the last one, please.
Okay, hopefully Dr. Hisham will figure it out. If not today, we will have him tomorrow. So let's go to the last lectures with Rawa Al-Raddadi.
السلام عليكم.
السلام ورحمة الله. حياك الله أستاذة رؤى. عذرا, is that your name? Am I pronouncing? Ravia, okay. حياك الله أستاذة Ravia. So the mic with you, go ahead.
Good afternoon. First of all, thanks for giving me the opportunity to participate in my research. My name is Rawia Raddadi. I have a master's degree in molecular biology from Taiba University, Medina, and I work now as an assistant in Center for Genetics and Inherited Disease. Fibroblast growth factor receptor 2, one of the genes that has been shown to be linked to an increased risk of breast cancer for women in different populations, which 5% of human breast cancer are overexpression and amplified of fibroblast growth factor receptor 2, which 4% for triple-negative breast cancer. Our topic today is fibroblast growth factor receptor 2 gene polymorphism and susceptibility to breast cancer in Saudi women. Now I will be giving you a brief introduction related to my research. Breast cancer is among the most common cancer affecting female and has second highest mortality after lung cancer. We have noted a significant increase in the frequency of breast cancer among Saudi women from 2000 to 2018, where the incidence rate in 2000 was 10.2%, while in 2018 was 29.7%. Several studies have shown how strong the relationship between the field of genetics and disease. One of these diseases is breast cancer. So we selected one of these genes that was not studied on Saudi women. Fibroblast growth factor receptor 2 is a tyrosine kinase receptor that are involved in very important processes, such as control cell differentiation, proliferation, and apoptosis in breast cancer. Fibroblast growth factor receptor 2 is located on chromosome 10. If GFR2 SNP I investigated in my study, it's located in intron 2 of the gene. There are several transcription factor binding sites in intron 2 of fibroblast growth factor receptor 2 in close proximity to SNP I investigated. The minor allele of the SNP acts as enhancer, altering the binding affinity of the gene for transcription factor, which induce upregulation of fibroblast growth factor receptor 2 expression in breast cancer tissues. Breast cancer susceptibility linked with FGFR2 in several genome-wide association studies and candidate genes studies. Polymorphism of SNP has investigated in breast cancer association in several populations. As we can see in the table, the association is strongest among Korea and West Siberia population, while it was not that much in North India. The purpose of this study, we did this study to investigate the association of a SNP variant and susceptibility to breast cancer in Saudi women, and to assess the association of polymorphism with estrogen receptor, proestrogen receptor, human epidermal receptor 2, and menopausal status in Saudi women. Materials and method. The study was approved from Taiba University and King Fahd Hospital committees. Data was collected from the registry and laboratory system. Formalin-fixed paraffin-embedded breast tissue samples were collected from 2011 to 2017. DNA extraction by phenol chloroform heating method. The gene was amplified by PCR. Then PCR product was digested by using fast digest restriction enzyme. Random PCR product sample were sent to Macrogene company. Genetic data was analyzed by different software. Finally, the data was analyzed and interpretation. Result and discussion. On genotype analyzed, significant genetic association between FGFR2 polymorphism and breast cancer in Saudi women was compared, where the result showed TC and CC genotype frequency was higher in case than control. Allele analyzed confirmed that the C allele was significantly dominant in the case than control. So there was significant association between C allele and susceptibility to breast cancer. It's known that menopause significantly affects the risk of breast cancer. When genotype of menopausal status was analyzed, the result indicated the frequency of breast cancer in women in the case premenopausal and postmenopausal was significantly different, where the SNP was associated with an increased risk of breast cancer in premenopausal, but not in postmenopausal. This is maybe due to the imbalance in the synthesis of both estrogen, proestrogen hormone, or due to the different population. Data was stratified by estrogen, proestrogen hormone receptor, HER2, and triple negative. Our result indicated significantly association between C allele with estrogen positive. Conversely, C allele shows significant association with both proestrogen negative and HER2 negative, and also shows high association with triple negative breast cancer. The association between estrogen positive and breast cancer possibly can be due to the interaction of FGFR2 variant with high level of endogenous sex hormone, especially estrogen, which may increase the risk of breast cancer. And low expression of proestrogen and HER2 reduce the growth and function of normal breast cell, thus increasing the risk. In triple negative breast cancer, the loss of estrogen, proestrogen hormone receptors, and HER2 from the cell reduced its growth naturally and therefore increasing the risk of breast cancer. The association between FGFR2 SNP and breast cancer risk is still inconclusive due to the ethnic regional variation and other factors. Conclusion and recommendation. The current study showed that FGFR2 SNP associated with susceptibility to breast cancer in Saudi women. The finding highlights fibroblast growth factor receptor signaling pathway in tumor development, and proves that FGFR2 could be considered as predictive marker that may facilitate the process of diagnosis and treatment of Saudi women. To replicate this study, large sample is needed. Additionally, to understand the effect of this polymorphism in pathogenesis, further functional study is required. Thank you for your attention.
Thank you so much,
Thank you.
for your lectures. If anyone has a question, Dr. Amir. Or any other item? Any other question?
Dr. Bashari, Dr. Hussam, he has a question.
Okay. Go ahead, Dr. Hussam. Let me just. Dr. Hussam, go ahead.
Yeah, thank you, Dr. Mshari, and thank you for, I think, Ruwaya. Rawia. Sorry about that, for the great and very simple presentations. My simple question is that, is there any purpose that you're using the intron 2 in the FGFR2?
Sorry?
Is there any purpose of using only the intron 2 among of all other introns in this kind of gene, or to do the SNP?
Because this purpose have a lot of studies in different populations about this SNP specific.
Okay. Thank you.
Thank you, Dr. Hussam. Dr. Amir, is there any other question?
I'm just wondering about the program that used in analysis of the genetic information. You have, do you know which program you used?
Yeah, she says.
Okay. Thank you.
Welcome.
Thank you so much, Ustad Rabia and your team for this presentation, and good luck. Thank you. So we will try the last one more time with Dr. Hisham. Dr. Hisham, are you with us?
Okay.
Okay. Can you enlarge it from the bottom?
I hope so. I actually changed the computer. Can you hear me, sir?
Yes, it's very clear now. Go ahead. You don't need to do anything. If you can go to the next slide, is that possible?
Slides is already present?
Yeah. We can see your slide. I mean, can you go to the next slide? Is it possible for you? Can you do it?
Okay.
If you can do it, just go ahead. Okay, go ahead, Dr. Hisham.
Is it clear now?
It is clear, yes.
So you can see your slide, my slides. Okay, thank you, sir. Actually, thank you for your patience. I actually changed the computer, the whole computer for this. My presentation is about tumor markers CA15-3, CA2729, and HER2 as a panel marker in breast cancer patients. I am Hisham Anwar, Associate Professor of Biochemistry, Department of Pharmacology, College of Pharmacy, Jove University. Well, just as an introduction, according to the reports of WHO, cancer burden rises with millions new cases every year and millions deaths every year all over the world. Breast cancer is the most common occurring cancer in women and the second most common cancer overall. Diagnosing cancer in late stage leads to inability to provide treatment, hence unnecessary suffering and early death. Clinical evaluation by measuring tumor markers are now developed in the last few years. Tumor markers are substances which can be measured quantitatively or actually qualitatively and quantitatively both Biochemical or immunochemical means in the whole body fluids, tissues, identify the presence of cancer, possibly the organ, because there is some specificity for the organ, for the tumor markers, to establish the extent of tumor burden before treatment, as well as for monitoring the therapy. The aim of this study is to facilitate early diagnosis of breast cancer patients participating in the present study by measuring the level of serum tumor markers for the three mentioned tumor markers, CA15-3, 27, 29, and HER9 individually and in combination with each other in the form of panel study. Material and methods. This study included 132 individuals classified as follows: malignant volunteers, 92, breast cancer, non-smoking, pre and postmenopausal woman patients with age varying from 25 to 86 years old, mean 50 plus or minus 1.25 standard error, were included in this group. According to the American Joint Committee of Cancer, the patients were classified into stage 1 plus stage 2, that was 18 cases, stage 3 was 31 cases, and stage 4, 43 cases. The second group is benign volunteers, 20 patients, non-smoking, pre and postmenopausal woman with benign breast disease were included in this group. Their age ranged from 25 to 73, more or less similar to the other groups. Group C is controlled volunteers, 20 apparently normal, healthy, non-smoking, pre and postmenopausal women. Age ranged from 28 to 75 years old. This is the figure for the distribution of the control, benign and breast cancer group in the present study. 70 cases for the breast cancer, 15 and 15 for both benign and normal control. This is the distribution of the tumor types. Actually, this study, there was a lot of patients. We chose some patients selectively for the study. The 34 cases for ILC and 66 cases for invasive ductal carcinoma. Stages, as mentioned before, 19 for stage 1 plus stage 2. For stage 3, there was 34. For stage 4, there was 47. Blood sampling. 10 milliliter of venous blood were collected from the controls patients with benign and breast lesion, as well as cancer patients. Sera were obtained by centrifugation of the clotted blood sample and then were divided into 3 aliquots and stored at -80 until time of assay. Routine laboratory investigation for the whole patients, complete blood picture, fasting blood sugar, serum creatinine, liver function are done for all groups. The biochemical study, CA15-3, was measured by immunoradiometric assay, cancer antigen 2729 by radioimmunoassay, and HER2/9 were measured by enzyme-linked immunosorbent assay. Results and discussion. We calculated the sensitivity and the specificity for the 3 major tumor markers, for the results, and we drew the ROC curve for the 3 measured markers. This is the ROC curve for 15-3. The maximum result we get is 50 5. I mean, the possibility for detection for the cancer. Ladies was 55. It rises to 63 with the marker CA27 and 2729. It was 69 for HER2/neu using different cutoff value. To summarize the results, we make a panel study. This figure shows the sensitivity of single, double, and triple panel study for the markers in the volunteers. As it's shown here, the double panel was maximum with 69 regarding the two markers CA15-3 and CA27-29. The double panel was for CA15-3 HER2/neu was 72.5, and the double marker for CA27-29 plus HER2/neu was 79. When we make a panel, triple panel for the whole studied markers was 87.35. It means that we can, in the lab, make the triple marker for the patient, for example, and we expect a positivity with 87.35 diagnosis for the breast cancer patients. Thank you very much for your patience, and I'm sorry for being late for the presentation.
Thank you so much, Dr. Hisham, for this lecture, and we like it. Thank you, Dr. Hisham. Is there any other question or any question? I think there is some question.
Yeah, if you allow me, I have one question. Thank you very much for your interesting presentation.
Thank you, sir.
As you showed us in the last slide, that the triple panel gave you around 88% positive. For which stage of cancer? Stage 1 or 2 or 3?
Okay, actually, this is for the collective stages 1, 2, 3, 4. Okay, because this is a very simple ray from our study. The study is it's more than 500 patients, and actually I collected this for the 3 stages.
Okay. Do you remember for stage 1 how the percentage of the positive?
Stage 1 plus stage 2, sir. It's paneled. Stage 1 plus stage 2, and it was around 60%.
Okay, thank you very much.
Okay.
You're welcome, sir.
The last question from Maryam Al-Utaibi. She's saying, thank you, Dr. Hisham, for this presentation.
Thank you, sir. Thank you for your patience. I'm sorry again for being late. Thank you, sir.
This is the last question. She has a question. What is your rationale of choosing these marks as a panel, as we have many markers can be combined?
Sir, this study started 3 years ago, and we have already in this study another 5 marks. So I just chose 3 from them.
Okay.
And these 3 marks, I just choose the best results for these marks. For the best results for these 3 marks was for these 3 marks. That's why I chose them.
Okay. So thank you so much for your patience.
Thank you, sir. Thank you, sir.
And finally, by end of this day, we appreciate everyone from the audience, participant, everyone who gave his lectures today. Thank you, Dr. Grant.
Thank you so much, Dr. Mashari. Thanks for all participants in podium abstract session. It was a great abstract, great output. Thank you so much for them. And I would like to extend my thanks to all participants, all speakers, all presenters during the whole day, and for the attendance and listening up today for this second day of the conference. Many thanks for all. Thank you so much, and see you tomorrow.
Thank you. Thank you very much.
Thanks for panel list staff. Thank you so much. See you tomorrow, guys.
See you.
Thank you so much. Thanks.